Ladies and gentlemen, we will begin the conference in 5 minutes. Welcome back, everyone, and thank you for being on time this afternoon. Hope you enjoyed your lunch. Also, welcome back to our 3,300 plus webcast viewers. If you are joining us for the first time today, we have a full afternoon planned for you that includes an open Q&A session at the end of the day. All members of our audience will have the opportunity to ask questions. So if you have not reviewed the participant instructions on how to send your questions in, please review the document that was in the email that was sent to you this morning. This document contains a SurveyMonkey link that you can follow to send your questions in at any time. Starting us off this afternoon is a panel that will feature MAO representatives from Etna and UCare. Each panelist will discuss her organization's experiences with alternative payment models, including successes and challenges. It is my pleasure to introduce to you Brandy Alston from CMS, Julie May from Etna, and Geeta Wooster from UCare. Please help me welcome them.
Good afternoon, everyone. My name is Brandy Alston, and welcome to the Alternative Payment Model session. Today, we'll be hearing from two MAOs, Etna and UCare. At the end of this session, you should be able to understand how these organizations are collaborating with providers to provide high-value care, and more about their experiences in the area of alternative payment, including successes and challenges. So what do we mean when we say alternative payment models, also known as APMs? Okay. Much has been said about the growing cost of health care and the need to find innovative ways to provide cost-effective, high-quality care. APMs have emerged as a way to accomplish this. These models are diverse, however, they share two primary features. First is an emphasis on value over volume. Both Medicare and private industry have been experimenting with payment models that move from rewarding volume of utilization of services to value-based payment structures. Second is an emphasis on care coordination, not unfamiliar to Medicare Advantage. And many APMs include provider incentives to promote increased care coordination activities. It's important to take a moment to acknowledge what's happening in traditional Medicare. Secretary Burwell recently announced the goal of tying 85% of all traditional Medicare payments to quality or value by 2016, 30% through the use of APMs. By 2018, this goal increases to 90% of all Medicare, traditional Medicare, payments tied to quality, 50% through use of APMs. There's a growing bipartisan interest in understanding APMs, the use of APMs to provide high-quality, cost-effective care throughout all of Medicare. So what does this mean for Medicare Advantage? Increasing the tying of payment to quality is an important shared goal among our leaders, this agency, and the industry. For instance, the 2015 MACRA tasked CMS with researching ways in which we can incorporate alternative payment models into the MA program. We are aware that many MA organizations have been experimenting with and implementing APMs for several years. We believe that this panel is a wonderful opportunity to hear from two such organizations, and that continued dialogue on this topic will be tremendously valuable going forward. Today, we'll be hearing from Julie, Vice President of Medicare Network, Operations and Strategy at Etna, and Geeta, Senior Vice President of Public Affairs and Marketing with UCare. Julie and Gita will each discuss their respective organizations' experiences in the area of alternative payments. And now I will hand it off to Julie. Thank you.
Great, thank you, Brandy. Appreciate the time, appreciate CMS inviting us here today. One of the things that occurs to me as I started thinking about this presentation, what I wanted to share, and lessons learned, and the journey that we're on, is one of the most important things I think you have to figure out is the acronyms. ACO, MSSP, JV, RISC, PHO, IPA, CIN, IDN, and I'm sure many of you can share some of the other hundreds of acronyms that come up with the different kind of provider organizations that you may be working with over time. So as we kind of talk today, we'll talk a little bit about the journey. The journey that we've taken at Etna, and certainly the lessons that we have learned along the way, and there's been many. And there will be many more to come. And we'll also try to highlight, kind of where our successes and challenges, because I think we learned so much from our challenges in this area. As I talk a little bit about Etna from a global perspective, we believe that Etna has this vision called Vision 2020, and it's our mission to build a healthier world. And as we think about the components of building a healthier world, we break it down into three kind of elements. And all of these help us kind of think about how we're moving away from a volume-based fee-for-service kind of arrangement and thinking about care in a way that is delivered locally, the right care at the right time and the right place by the right providers, as well as having this member-centric kind of experience throughout the selection process and the decisions on their care. And it really starts us to think about how we need to redefine both how providers are reimbursed and how we engage with them and what roles each of us play along the way. This shift in a more outcomes-based kind of environment has really had the effect more globally to begin to start to transform care. And when you start to transform care and see outcomes improved by the specific methodologies that you take and the contracting structures that you deploy, you really start to enter into the realm of value-based contracting that becomes both valuable to your providers, the members, the patients, the beneficiaries, and you as the carrier and the MAO. One of the things I would say that was most important for us, or a lesson learned, because I'm sure we didn't get the timing quite right, is to really think about accelerating this transformation from fee-for-service to value-based. And what the outcomes that we want here needed to be kind of spelled out in advance by the organization. To really start off with kind of how are you going to implement these APMs, if you will, the new acronym. How are you going to implement these types of contracts, and what are they going to look like in the future? How are they going to transform the way you deliver health care? And thinking about how you're going to engage providers and consumers along the way. So as we took a step towards this, we kind of put together some tenets of things that we thought would be important. Initially collaborating to allocate care management and care delivery responsibilities. And what I mean by that is that oftentimes there are provider groups that you'll work with that have a population health perspective, and they will have care management teams that work with the beneficiaries, as well as your own utilization management, care management teams. It's really important to get those two groups together to coordinate, because if you don't, what happens is everybody's calling the member and telling them that they need to get a test done or follow-up care, or how is their hospital acute care and their experience in subacute. So putting together that collaboration model with the care delivery responsibilities of the organization, keeping in mind as an MAO, you always have that end of the day responsibility that your contract requires you to have either perform the action or have a formal delegation and oversight performance structure. The second item was really fully utilize the multidisciplinary resources. Oftentimes when we deal with some groups, even the larger integrated ones, they don't have all of the components. They may not have a pharmacist. They may not have a behavioral health specialist. So making sure that you really understand the strengths of the organizations that you're working with and how you can complement from a multidisciplinary perspective is really important up front. Utilization and point of care tools, can't talk enough about that. what's really important when you're working with these organizations is that understanding that the more that you can be part of the provider's workflow, their current process in their clinics, in their operations, the better and higher performance and better outcomes you'll have. For example, if you want the provider to close gaps in care, sending them a list and asking them to execute on it isn't the most ideal. Integrating that data into their EMR system, when the patient comes in and here's a list of things that we need them to address in addition to any other reason that they're in the office for a visit, that's the kind of integration that is helpful for a provider, as well as you providing them information about, did they have an ER visit? What specialists are they seeing? So if you think about it from a PCP perspective, it's really good to have that holistic approach. Next is really the exchange of data, as I was talking about, thinking about the different areas of care which the beneficiary is accessing. Having their pharmacy information at a provider's fingertips is also very helpful. Sure, thanks. Hopefully that's a little better. Act on opportunities to improve care quality and efficiency. So there's a lot of data analytics that you'll want to put in place with these types of contracts, and those analytics will drive kind of some of your performance outcomes. Test those results with the provider. Ask them if they're correct. What is the tactical plan to approach them? So as you continue to kind of generate the support for thinking of what you want your outcomes to be, really thinking about how value-based contracting transforms your care, as part of your design process, really start to continue to hone in on what is going to be the difference between a fee-for-service environment to what you want to achieve in a value-based contracting environment. And this slide really talks about some of the variation and how you would really move the needle on how you look at care within your organization and interaction with your providers. And the lessons learned from this particular one is to really take your time to map out the different outcomes you expect to see, making sure your teams are all aligned with these kind of conversations, both in your local geographies, at your corporate level, with your providers, and having this foundational structure in place so the messages that you're delivering to your provider networks are consistent, and they can understand the value proposition that starts to emerge for them. These are important core principles in kind of the development of your process. But believe me, if you don't have it all done before you launch your value-based work, you can catch up pretty quickly. So as you continue to think about what kind of contracts you're going to have in place, you begin to think about your network structure and the benefit strategies that are going to start to evolve. And so as we think about and identify providers that are really aligned with us philosophically and where we want to go, we begin to develop kind of outside of your base network, these level of network providers that become very collaborative, and then eventually or potentially you can develop products around specific providers that have like-minded approaches to the delivery of care and performance and outcomes. This is kind of a trade-off as you think about it from a sales and marketing perspective, because you are going to have a narrower network. It is going to be less choice for beneficiaries, but ideally the end game is that you are performing at a higher quality outcome more efficiently, and that will drive better benefits in your geographic area. So the fact that there's a narrower network, although you still have to meet accessibility standards, really does have beneficiaries start to think about the different choices that they're going to make. Am I going to make a trade-off for not having a broad network, to have a narrow network, but maybe the benefit over time becomes richer? That's actually one other thing I would kind of mention, is that the narrow network products oftentimes in various markets have a slow growth. And it varies by geographic area, but keep in mind that over time, and as you all know, the base period bid and all of the data that you're going to start pulling into with these value-based arrangements are going to start to drive more efficiencies in your bid outcomes and bringing in better benefits. So the comparison over time with a narrower network theoretically is really going to deliver you a bigger value proposition into your market. So keep that in mind as part of your end game, if you will, as well. So if you have, you want to start value-based contracting or thinking about it more broadly than you already are, we kind of think about it along a continuum, a contracting continuum. And at the bottom of the pyramid is really kind of the foundational, kind of what you do every day, managing medical costs and quality. And as you start to change the contract types, you begin to move the care more to a transformative model. And this transformative model here, projected in a pyramid, really represents your contracting value chain, the continuum of contracts. And the progression through that value chain, has potential with each of your providers. So as you think about the structure, you're going to want to think about where providers are within this value chain and what's the appropriate place to start them or move them. And so one of the things that I would say is a really big tenet for us as well is thinking about this pyramid, this contract continuum, and thinking about where the providers are in terms of their capabilities, and are they able to kind of move to a more intensive level of accountability. And in doing that, we actually look at providers around 6 different categories or facets of their ability, starting with kind of on the geographic opportunity, looking at what are the growth of their practices or their integrated systems, what's their patient satisfaction rate, what's their differentiation, what do they do differently than anyone else, is it something that's kind of sets them apart. We have to look at their operational efficiency. Can they do cost management? Do they have a good understanding and history of execution of internal performance improvement? Do they have those qualities and capabilities within their practices and within their systems, acute, subacute, et cetera? Physician alignment, can't talk about this enough. Really, is there governance and leadership within that group or that system that you feel that you can have, a medical director that really is a physician leader that you can work with your medical directors pretty comprehensively? How collaborative are they? What's their information sharing kind of techniques and opportunities? Care transformation, what care delivery models do they use today? What clinical data alignment do they have? Are they managing referrals? Who are they referring to? What are their referral patterns? How do they assess the value of the specialists within specialist hospitals, subacute, all the ancillaries within the networks that they're currently operating in? Patient engagement, what are they doing to make sure that there are engagement plans with those patients that need extensive planning and extensive chronic care management? A physician told me once that in order to be successful in Medicare, you have to take preventive care and make it a religion. I think that if you talk to providers that have those kinds of base concepts, those are the ones that start to align with your thinking and how you want to drive towards outcome-based performance. And then, of course, finally, financial stability. As MAOs, we have responsibility to our beneficiary not to put these providers in a risk position that they're not capable of managing. And what I mean by that is, if you've got a provider that maybe is performing at, let's call it an MLR that's 95%, and you want to put them on a risk deal where they pay up and downside risk, and without the techniques and tenets and activities and tactics to move them to a better MLR performance, you're essentially setting them up for higher cost. So you have to be very careful about the financial stability along the contracting continuum, that you don't want to put a provider in a position along the top of the pyramid that they're not yet ready for. Doesn't mean they can't get there, and they can get there with your help. But it's very important to make sure that as you continue working with them, you really understand their strengths and weaknesses. So to summarize, from our perspective, a bit of the challenges and successes that we've kind of run across, you can't emphasize enough, how much you have to have the providers be ready for the contracting positioning you're putting them in. You really have to make sure the accessibility standards are met. The one other thing I would tell you that is really challenging, I'm sure many of you have experienced, is the integrating disparate systems and levels of practice. What I mean by that is oftentimes you have groups or IPAs or other arrangements where the downstream providers have variant EMR systems or maybe none at all. So you really have to figure out how you're going to get into that physician workflow. Changing their workflow doesn't work. You getting into it to make sure that they can kind of deliver care and focus on some of the outcomes is key to your success here. And that is I think one of the big challenges I would say that we've experienced. On the positive side, certainly the documentation has been better. STARS metrics have actually improved in arrangements where we have collaborations with providers. We have data that actually supports that now. We've gotten enough time in the trenches to be able to say that. And really, the opportunities that this has created just in the discussions with various providers on, how do we work together? How do we collaborate? How do we integrate? How do we coordinate the care? It's really those conversations that you want to have with those providers that become now long-term partners. And that's really how we think about it here in Etna and think about moving towards a healthier world. So with that, I'll turn it over to you.
Good afternoon, and I also want to thank CMS for allowing us to participate in the conference. UCare is a regional nonprofit health plan, so I think the differences between how we are approaching value-based purchasing from what you just heard from Etna, there's going to be a ton of similarities, but as a smaller size plan in a more focused marketplace, we really need to be very connected with our providers and assure that we will have success, because the market isn't very forgiving when you're sitting right in the middle of it the whole time. We have about 95,000 Medicare Advantage members across 87 counties in Minnesota, and we have a little over 10,500 dual eligible, fully integrated members in 66 counties. And some of the examples I'm going to give about what we're doing on value-based purchasing are a result of work we've done with our dual eligible program, along with our Department of Human Services for Minnesota Senior Health Options in Minnesota, and then what we've been doing with our Medicare Advantage plan separately. We started doing a lot of the work on value-based purchasing from the Minnesota Senior Health Options perspective. So I think that probably is foundational to why you see the social system of care coordination as part of our slides. In looking at community resources, the family caregiver, long-term supports, and how all of those social supports weave around a member, even when we're dealing with a Medicare Advantage plan, we keep that in mind. And although it's not always part of the benefit package, we always are thinking about those support systems as we put our programs together. Our value-based contracting model has been in place for quite a few years now, but it's been an evolution for how we've grown. So we have total cost of care contracts, we have pay for performance, we have shared improvement opportunities so that we can include everyone in our pay for performance, even if they don't believe they're going to reach the target that we're looking for. And then we've been developing an ACO model with several fits and starts, working with different providers in our community. And at my last slide, I'm going to talk about one that we're rolling out for January of next year. The provider selection process has been very clear for us. We know that there are providers who in our marketplace are in the Pioneer ACO, they're in Medicare Shared Savings, and they've come to us now struggling a bit, not fully understanding that when they took on Shared Savings, they were serving disabled and that were duals in the program. And so it's been a very positive discussion about how to coordinate all of the services together and align. Also, the measurement that we're going to look at when we're putting together these programs have been aligned very much with the STAR measures so that we're all basically rowing in the same direction. I put this slide in just because it's been very important for me to always remember the complex social, economic, and medical environment that we're working in. We know that with a Medicare Advantage plan in Minnesota where there is a premium for everybody to pay to be in the program, we need to acknowledge we may not have the lowest income folks picking our plan, but the role clarification, there's so many different support systems in the community, and as we've talked to providers about ACO development, we always talk about the fact that it's a population health type model. That pyramid that Julie was talking about is incredibly important for this to be successful, and not all of the provider systems think about that full social environment and the need to acknowledge all of the social service agencies or programs like the federal government has with Senior Companion Program that might be just the ticket for someone versus another benefit. Our payment model discussions have been very straightforward. We've had quality-based incentives, financial gain share, and it's been a struggle to get people to want to go to the full risk type of model, and then what we're all calling the full payment transformations. Prior to this year, our only accountable care organization model was in our very limited commercial space. We're in our exchange product with about 10,000 members, and we actually developed a very integrated ACO model with one of our larger care systems. And that was helpful, but not enough as we were developing our Medicare model. So for our purposes, and we put this slide in, we looked at payment models and we put them into the simple structure buckets and the more integrated buckets. And we're not a plan looking to have a full merger, but we wanted people to understand the bookends, and the simple structures are more what I know CMS is trying to move away from in fee-for-service. But the shared governance type of models really are much more complicated to develop if you want to be successful. I put one slide in here on 3 initiatives that we have in place today in Minnesota for our integrated full dual integrated model for MSHO in Minnesota. These are more targeted initiatives for the chronically ill, and I thought it was important to acknowledge that for us, it was as interesting and important to have programs that targeted chronically ill duals as it is to have the more healthy seniors that are going to be in a Medicare Advantage plan. Fairview Partners is an initiative that has been working with us actually since 1997. They're a subset of a very large care system in Minnesota. They developed a program that started working in assisted living and nursing facilities. It's a very intensive care model, but when we aligned with them, one of the agreements was that the nursing homes were part of the risk model. They weren't just a place people lived, but they were integral to making the program operate. The next example on here, Care Choice, was started with a nursing home co-op in our state, and they wanted to drive the care model, and then they chose providers that were aligning with them. So different way of looking at the model, but both targeting very chronically ill individuals. And then Bluestone is a physician-driven primary care virtual system, and they will go into foster living facilities, assisted living, and they create a relationship with those care settings to really have an integrated program that can serve some of our more complex members and really target individuals with significant behavioral health conditions for us. Now, this is in our dual program. As we've talked about our care transformation moving into the payment part, we always start with the care system model that's in place, and looking at the care model that's operating, how the physicians within that system are paid, the service model that they have operating, how we can share data. Julie talked about the importance of how you can integrate the information you're sharing right in the electronic medical record. Otherwise, those lists really have to be handled and manually distributed, and it's not very efficient. And then having all of the financial alignments so that all of the components for the full continuum, whether or not they're owned by the provider, have to be included in the discussion. Our guiding principles were very straightforward. We wanted to create a member experience that would differentiate and drive loyalty. As Julie said, if you're going to have a more narrow focused network, you have to have a reason for people to be in that system. We struggled on the network adequacy requirements with the system I'm going to describe. We were able to meet CMS requirements, but we needed to create a local PPO rather than our HMO model because we bumped into meaningful difference requirements for our CMS application. And please have that as a footnote from me, that that is a barrier to doing this, even if you can meet the network adequacy. Having a product with benefits that are fairly aligned with what you're already operating in the marketplace can be you can bump into the meaningful difference area. We needed to have incentives that would align with the services that the provider could do. We knew that we might have to have some authorizations in that system that weren't in place for our traditional HMO point of service product. We wanted to avoid administrative duplication, and clearly we needed to be as functioning streamlined with this operation as was possible and keep the costs down, so that was an important discussion. The brand loyalty of the individuals in the care system we chose was really important, and we knew that from our previous discussions. So we have strong brand loyalty. The care system had strong brand loyalty. They needed to be a high-performing network. Now, in our Medicare Advantage plan, we're a 4.5-star plan, and we needed to make sure we weren't selecting someone that was actually going to have trouble with keeping up that star measures level, and then the incentives needed to be fully aligned. The collaborative partnership and development is going to be rolling out now with a January 1st product. It's called Essentia Care. It's with a system in northern Minnesota called Essentia. We took 18 months to develop this program, and Julie said you can have a few things that you work on after, but we were probably a little retentive in making sure that all the I's were dotted and all the T's crossed before we put this into the bid. And we're really proud of what we've been able to put together. We called it Essentia Care to keep both names connected in this, and there is a true integration of the systems where there are some things we usually do on chronic condition management that the care system is going to do in this case, but we hope it's going to be an example that we can replicate with other systems, but it's going to be a true pilot test for us, and I can't understate the work it took and conversations to get to this rollout of the product. Thank you.
Good job.
Hey, I wanted to thank Brandy, Julie, and Geeta for sharing their experiences with the alternative payment models with us. We are out of time, so please send in your questions and we will address those during the open Q&A session later today. Thank you. Okay, I'm back. Our next session will provide pointers to both enhance the appeals submission process and better utilize the information, the Maximus Federal Services Appeal website, to monitor health and prescription drug plan performance. From the Center for Medicare, we have Rita Worm, and from Maximus Federal Services, Kathleen McGinnis.
Good afternoon. My name is Rita Worm, and I am the Director for the Division of Appeals Policy in the Medicare Enrollment and Appeals Group. For this session, we would like to spend some time talking about the Part C and D appeals. We are joined by Maximus, the Part C and D independent review entity, more commonly known as the Part D Quick. Maximus will be talking with you today about several different topics. The notice of dismissal of appeals request forms. They're going to talk about information that you need to include on the model form that will help facilitate the identification of the items services or claims that are at issue, tracking appeals. Our presenter today will describe ways in which health plans can use an online tracking tool that's located on Maximus's website to track the status of your appeals or these cases throughout the course of the year. You can do this on an ongoing basis rather than at the end of the year. CMS strongly encourages plans to do that. Auto forwards. Maximus will share best practices for sending these Part D cases, the files, to the independent review entity, or QUIC. As a side note, over this past year, CMS has noticed an increase in the number of cases being auto-forwarded to the Part D QUIC. Because of the cost to the program, we are looking at the reasons for these auto-forwards and ways to help plans to come into compliance. We hope to share more about this in the 2017 call letter with you. Although we are not discussing the point of sale pilot in today's presentation, I do want to give an update and let everyone know that we are currently working with a small group of plans and PBMs to identify a process that can be implemented in response to certain point of sale rejections that will allow the enrollee to obtain coverage for the requested drug or an appropriate formulary or off-formulary alternative. Again, we hope to share more about that in the 2017 call letter. Now I'd like to introduce you to Kathy McInnes, Project Director for the Part C QUIC. Kathy's been employed by Maximus since 2005 and has served in a number of capacities and worked on a number of projects for both the Part A and the Part C QUIC prior to assuming her current position as Project Director. With that, please join me in welcoming Kathy McInnes. Kathy?
Thank you very much, Rita. Let's hope that I can do this correctly. Okay. I was going to be joined today by the Part D Project Director, Mark Remillard, but he got called for jury duty, so I'm sorry. I have his notes, but please don't ask me any difficult questions about Part D. We're going to cover dismissal reviews, some Part D auto-forwarded appeals, and then the use of our websites. We've noticed some opportunities for improvement. The Part C notices of dismissal do not always include enough information to connect them to the correct appeal request. And as I'm sure you're all aware, sometimes providers send in huge batches at once and sometimes have repeat customers in their offices or getting supplies. The auto-forwarded Part D case files are not always complete and they're not always accurate, so we wanted to find a way to help you understand that better. And we find that at the end of the year, just before the star ratings come out, we have a flurry of activity and are hoping to kind of alleviate that for both you and for us, as well as for CMS. Following the presentation, we hope that you'll be able to send those issue the dismissal request forms in such a manner that when they come to us, we know exactly what case is under appeal, and you can get that to us promptly. To make sure that your auto-forwarded Part D appeals are correct and complete when they come to us so that you don't have to go back and visit them one more time. And to utilize the Maximus websites to monitor the status of your appeal cases. With the Part C dismissal reviews, it's a pretty simple process. You issue your notice of dismissal. The appellant then says to Maximus, "Oh, no, I wasn't done timely. I had all these reasons," or something else. Often, I don't have to sign a waiver, so I don't know why they asked me to. We typically ask you for the case file within the same day that we get the request or the next business day thereafter. And then, according to the rules with CMS, you do have 24 hours to submit the case to us. Practically speaking, We do have staff who work on Friday evenings. We don't expect you to be sitting at the office Friday night at midnight waiting to get that request for a case file. If you pop it in the mail to us on Monday morning, that's fine. Doesn't have to be exactly 24 hours. I would also say that you do not need to use overnight mail. Certainly you can use next day air, but that's an unnecessary expense for you and just makes it a little crazy. Our review begins when we receive the case file from you. And as a reminder, if we do overturn your dismissal, you'll need to complete a substantive review on the appeal. If you've dismissed the request at your level because the request was not timely, and we find that the appellant had good cause, but they're a representative and there's still no appointment of representative form, you still will need to ask that. And you may end up dismissing the case again because, for example, they were not an authorized representative. And if sometimes we get appeals that are marked second level appeals that we get from your contract providers where you've dismissed their request, if that happens, please don't just not send us a case file. Please send us an email or a note letting us know that those are contract providers and therefore you don't have a case file to send and they have no appeal rights through the IRE process. Look at my notes here. And a piece of good news, I guess, for you, when we overturn a dismissal, that overturn date becomes the date that you received the valid appeal request. So you don't need to go back to the original date when you're filling out your reconsideration background data form if you end up upholding your original denial. I'm sure you're all very familiar with this form. And one thing that we've found, a couple of things which health plans have done, which have made it very easy for us to all locate what we need, is by adding your appeal number or your claim number to the upper right-hand corner of the form. If you do that in the area just above the title of the form, it will help both you and us to make sure we're dealing with the right appeal. And some plans have also added their dates of service on the form or in the description of why the appeal request can't be processed. We find that also is very helpful in making sure that we're all looking at the right claim. And now on to the part where I am most shaky. Most drug appeals are made by prescribers, so it's critically important that you include the correct prescriber name, address, contact information, especially their telephone and/or fax numbers, as well as the enrollee's HIC number, so that our communication with the prescriber is directed correctly. We often need to fax additional requests for information to the prescribers, and if they are the appellant, we are also faxing the decision letter to them. If you enter incorrect information, we run the risk of creating a PHI incident for everyone. The evidence of coverage and the formulary are critical in cost-sharing appeals. Sending them by CD saves trees and time for both the health plans and for Maximus. And as a reminder, if you've approved coverage of a drug but your approval was not timely, please include a copy of your notice or your letter or a screenshot of your authorization when you send the auto-forwarded case file. If you don't, we'll need to ask you for it, and that will delay not only the notification to the appellant, but it will also mean that you've got to go back to that case file 3 times instead of just once. Plans should also contact your CMS account manager when you're sending large volumes of auto forwards at one time. Your manager needs to be aware that you're having that issue. When you're using the Maximus websites, you can do a number of different things. You can look at your appeals cases. You can make sure that we've gotten notices of all the effectuations you've completed. You can use them to double-check regulations and other resources, and you can look at health plan data to see how you compare with other health plans. We update the websites daily, Monday through Friday, usually in the morning between 8 and 10, so if you try to access them at that time, you may find that you get a little glitch or a little answer that doesn't seem quite correct. And I also would say we do update the information as it comes from the Medicare appeals system. So if that system is down, our updates are delayed, sometimes by as much as a day. We do know that. The website addresses are here, and they're also in your conference guide on page 21, as well as in the printout. This actually is the Part D website. It contains information for enrollees, prescribers, physicians, and health plans, as well as information on regulations, links to the Medicare and CMS websites, and other resources. And of course, information about Maximus and our contact information is also available on both websites. And as you see this group doing, enrollees can use our websites to search for their appeals cases. For enrollees and plans, the process is the same. You can search for cases by appeal number, by plan number, by Maximus decision date, or by Maximus receipt date. So if you know you sent a huge batch of cases on the 12th and you sent them overnight, on maybe the 14th or 15th, you can check to make sure that we got everyone that you sent. I would note that the LEP appeals information is not included on the website. The website includes only drug appeals. The Part D website includes only drug appeals, and the LEP appeal status you can get by contacting our customer service office. So here are your appeal search results, and one of the enrollees is happy. As you can see, we fully reversed the plan denial. But the information that's provided is very similar. It includes the appeal number, the plan contract number, the date we got the request, the appeal priority, and how we received the request, the date we requested the case file, the date on which we received it from the plan, any tolling information, and our decision, as well as information regarding ALJ or reopened decisions, and the date on which the most recent decision was made. Please note the little tiny red number in the lower left. If your search were to return more than one page of results, all page numbers will be listed in this area, with the number of the currently viewed page in red, just like your favorite online shopping site. And for those of you who don't do online shopping, check with someone in your family. Everyone seems to do it now. Additional resources include forms for both enrollees and a procedures manual and other forms for plan use. We try to sort of have it be helpful for everyone. The Part C site. Enrollees can use this site to learn more about the appeals process, reporting their quality of care concerns, and their rights as regard to appeals. They can also search for their appeals or request a copy of their appeals case file. And some plans have directed their enrollees to this page to look for information as to how to file an appeal, which may make things a little smoother. Health plans can find the Medicare Advantage Reconsideration Process Manual, the forms you'll need in the appendix, including the Reconsideration Background Data Form, which will be revised and released shortly to include the date of your phone call on an expedited case. We will still want a copy of your phone log, but we have added that at the suggestion of one of the health plans. There's also links to the CMS website and to the Medicare Managed Care Manual itself. And of course, you can search for appeals and effectuations. Looking at the effectuations search page, it's very similar to that for the appeals search pages, and it's the same on both the Part C and D websites. You enter your plan number and select either the Maximus decision date, the date we got your notice of compliance, or the date on which you effectuated the decision, and the period that you want to review. You can look at as much as you want. You can look at a single day, you can look at an entire month, you can look at an entire year. We strongly recommend that when you're doing this, you look at the single month at a time. The entire year can be kind of overwhelming. For example, this search for receipts for a particular case from the 6th through the 10th of July shows the ones that have been returned, and you'll see the compliance notice receipt date and the date that you actually effectuated it. And again, if you had a number of effectuations, the little number in the left-hand corner will tell you what page you're on. Okay. I'm sorry, I shouldn't have said that, I guess. The last thing I wanted to call your attention to is the data on the Medicare Advantage Plan appeals, which have been conducted by Maximus. This data goes back to 1997 and is current through 2014. The aggregate data is provided by service and by health plan. The slide was truncated at 2004. I tried to print it showing all the years, and it was so small you couldn't read it at all. But you can look at the full universe of appeals that we've processed and see how your plan's percentage of upholds and overturns and dismissals compares to others. And you can look at that by both services and priorities, or you can compare your plan to others, should you wish to do that. This has been a really brief overview of tips and some best practices. As I noted, the website addresses are both on the slide and in your conference guide. I've answered some questions. What other questions do you have? Here comes Stacy.
Hi, I'm Tina Tyson with Kelsey Medicare Advantage. I have a quick question. You stated the LEP appeals are not offered on the website. Is that a plan to have it there?
At this point, I'm not certain, and I'm sorry Mark's not here, but I will pass that on to him and ask.
Thank you.
Sorry.
All right, we did receive a couple questions from our viewing audience that I would like to take the opportunity to ask. And the first question is, several of our failure to timely file dismissals are overturned. Why?
This is sort of an easy one, sort of. There are a number of reasons why we might overturn a failure to timely file dismissal. Sometimes people will send us long, involved letters. They were in the hospital, they were out of town when they had the service, which is why it was denied, because it was in an out-of-network facility, and they were recuperating at their daughter's home in wherever, which is not where they live, and their mail wasn't forwarded. We find that kind of thing to be a good cause for late filing. We also will find good cause for late filing if your denial notice did not include all the rules for filing the appeal. So if you fail to tell them that they have 60 days in their notice of denial, then we're going to find that if they didn't appeal until day 70, they had good cause. And what we frequently find is that people don't really file an appeal until they get a bill from the provider, and the provider may have appealed to you, been denied again, and now they bill the enrollee, and magically the enrollee realizes that that explanation of benefits really was meaningful.
Okay. And we have another question from our viewing audience. When we work with Maximus for our state commercial business, we are given the option to upload external review cases electronically via an application called Move IT. When will Maximus Federal Services implement the Move IT application or a similar secure electronic upload process for Part C and D appeals?
It would be much better, I think, if I weren't tapping this all the time. Sorry, I kept resting my finger on that and wondering why the slides were moving. We do have in progress the development of a submission portal, which will be rolled out in the spring of 2016. In the meantime, we are investigating the use of MoveIt for health plans for submission of their case files. We've gotten permission from CMS to move ahead with this as an interim step before we open up the portal, and we'll be testing 1 or 2 health plans and then making it available to more of you. If you're interested in using Move It to submit your case files, my contact information is on the next slide, I think. So reach out to us and ask, and we'll put you on the list of people who are interested in looking at that.
We do have time for one more question, and we have someone from our in-house audience here with a question, so go ahead, please.
Thank you. Hi, my name is Colleen Miles. I'm from Capital Blue Cross. We were just curious to know if there was any way possible that we could add our own appeal ID number to the status report we pulled from Maximus in order to be able to reconcile our data universes with the Maximus report to make sure that we're gathering all the information we need.
I can make a note about that. I don't believe that your appeal number is part of the data that's captured in the Medicare appeals system at the present time. So let me make a note of that, and I will follow up with that.
Thank you
and if
very
you want to
much.
just catch me before I leave and give me your information, I'll let you know.
Perfect. Thank you.
Is that it? Okay. If you have questions about appeals or processes, please call our customer service number that's listed right here. Email medicareappeal@maximus.com. Contact either myself or Mark Remillard. I did tell him that I would be revealing his email address and his direct phone number, which is 585-348-3240.
Check, check, check. Check, check. Podium mic, check, check. Check, 1, 2, check, check. Check, check, check. Check, check, 1, 2, 1, 2. Check, check, 1, 2, 1, 2. Check, check, 1, 2.
we're 15 minutes behind, but we're going to shorten the break. So take as much time as you want. So you had 40 minutes? Okay. Yeah, I mean, I would, but you can do like 30 minutes. So you can take 5 minutes off the break, full 5 minutes on Welcome back, everyone. We had, for our viewers, we had some thunder and lightning and it's storming, so our power went out on our audio and video. But we are back now and ready to get started. We will do our best to stay on schedule today. Our next session, or in our next session, I should say, Carrie Casey is going to lead us off by sharing key updates to the 2016 Medicare Marketing Guidelines. Following Carrie, our panel discussion will be led by Jeremy Willard and will focus on recently changed requirements for the provider directory. Please help me welcome Carrie.
Hi, good afternoon, everyone. I will be talking today about the top 5 changes to the Medicare marketing guidelines. So, thank you. So the first change we'll be discussing is a new requirement regarding documents to be posted to websites by September 30th. We have a couple of changes related to directories, and then finally 2 updates to disclaimers. So to get us started, plans are now required to post the following documents to their website by September 30th. The ANOC and EOC, provider or pharmacy directories, formulary and utilization management documents, and the multi-language insert. Now we know not all plans are required to provide the ANOC EOC by September 30th. So if you're a new plan, the applicable documents need to be posted between October 1st and December 31st. Don't worry, we know you don't have an ANOC, we're not expecting one. DSNPs and MMPs that separate the ANOC and EOC should post their ANOC by September 30th and their EOC by December 31st. Section 1876 cost plans that don't offer Part D should be posting their ANOC and EOC by December 1st. Now, our most common question on this issue is, do you really mean it? And the answer is yes. We do expect these documents on your website by September 30th, unless you're one of the exceptions noted on the previous slide. Now, we've had a big change to mailing of hard copy directories. So plans, you told us times have changed, and we heard you. You're now allowed to provide a notice directing your enrollees to an electronic provider or pharmacy directory instead of a hard copy. Now, some of you can probably tell me just how many pages of printing that is going to save you, and we believe we can do this while still providing enrollees with the information that they need. So our most frequent question on this topic is, when you provide a hard copy directory, does it have to be current and up to date? And the answer is yes, it does. It's true, we've gotten this one. Plans may provide addendums rather than reprinting the directory if information has changed since your most recent printing. Now, as for updating the online directories, we have some new requirements here. So the online provider directory must contain a notation indicating a provider's availability to new patients. Plans should be contacting providers on a monthly basis to ensure that this information is up to date. And plans should be updating their online directories anytime they become aware of changes. Now, our most common question on this issue is what constitutes monthly contact with providers, and our panel will be discussing best practices around this, so you're going to hear about it next. Now, we have two changes to disclaimers that I'm going to talk about now. The first is in section 50.2. There's a disclaimer that says benefits, premiums, co-payments, or co-insurance may change on January 1 of each year. So please note that the formulary, the provider network, and the pharmacy network have been removed from this disclaimer and placed in a new disclaimer in 50.15. This new disclaimer states that the formulary, pharmacy network, and provider network may change at any time. There's also a new disclaimer for Part D sponsors with limited access to preferred cost-sharing pharmacies, so please be sure to take a look at these. Now, if you still have questions, the Medicare marketing guidelines are available online. We've released 2 HPMS memos regarding the updates, and you also have your account manager, your marketing reviewer, and the marketing mailbox to contact at any time. We also understand that we've gotten many questions in from conference attendees. We'll address the ones that we're able to at the Q&A this afternoon, assuming there's time, and if not, we'll be responding through email with the marketing mailbox. So I'm going to turn this over to Jeremy Willard now to get started with our panel.
Everybody hear me okay? Good afternoon. Very happy to be here, and I'm also happy to be sharing the stage with the panelists here. We have Deb Schreiber from United Healthcare, Richard Appel from Cigna Health Spring, Sherry Stanley from the Health Plan, and Mark Hamelberg from AHIP. Given our... Closer? Okay. Is that a little better? All right. Appreciate it. Given our weather event that kind of knocked some time away, I'm going to really not rush through, but kind of abbreviate some of what I was going to talk about today so that we can spend the bulk of the time discussing as a panel, as well as those in participation, some of the kind of ideas that we have to gain compliance with regard to the new requirements as they apply to the provider directories. Our goal today is really to create an open dialogue, and it's going to be a dialogue that goes beyond just today. And we really hope that this dialogue helps to shape the direction and the methods used for provider directory oversight. To begin with, we're going to be looking at it, what I like to think of as the short term and the long term, coming into compliance with some of the new requirements, as well as looking for long-term opportunities to kind of better streamline things. I'm going to start off by giving some background information, and again, I'm going to abbreviate that somewhat. We're then going to talk as a panel first in the more short term, looking at some of the challenges that are presented as a result of these requirement changes. And then we're also going to look at from a long-term perspective. Mark's going to talk a little bit about a pilot project that AHIP's working on that is a more global approach. We're then going to open it up to kind of a continuation of that conversation. And I really want everyone, whether you're viewing online or you're here in attendance today, to be empowered by feeling like you're the 5th panelist or the 6th panelist now that I'm sitting here. But so that you can participate. We really want to hear the challenges that you're seeing. We really want to see the direction you're heading, any best practices, any questions or anything like that. I think that's the true value of why we're here today. So, a really brief history, and I think many of us are aware of this. There was, in December of 2014, a JAMA article in JAMA Dermatology that talked about the accuracy of provider directories as it applies to dermatologists. And at a very high level, I won't get into the nitty-gritty details, but it was not a very flattering article on the MA world. Some of the headlines from that article were that 45% of those providers listed in the directories were duplicates, and of the kind of other half that were not duplicates, only a little less than 50% of the time were the authors able to use the provider directory to contact the provider, have the provider agree to accept that the plan, have that provider agree to accept new patients, as well as being able to secure an appointment with that provider. So really, like I say, not the kind of headlines that we would like to see. And as a result of that, we have seen within CMS an uptick in the number of congressional inquiries as well as media inquiries around provider directories as well as network adequacy as a whole. As a result, or subsequent to the JAMA article, we conducted our own internal review looking at the about 2,100 directories represented by 21 different parent organizations. And I would say at a high level, while the findings were more favorable than what we see in the JAMA article, they were by no means what I would consider to be passing. And we did see a lot of the similar types of things that the JAMA article talked about as far as duplication, providers not accepting new patients. In addition, we've also had some anecdotal information, this in the way of CTMs and provider complaints, which I think have just given us further credence that there is indeed a reason to be a little concerned over provider directory accuracy. As a result of that, CMS really stepped up to try to shore up the guidance with regard to provider directories. In the 2016 call letter, we talked about the need for monthly communications to the providers, the notation for providers accepting new patients, as well as keeping an online directory that's updated in quote-unquote real time. These would be what I consider to be the short-term needs to kind of address some of the concerns that have been brought up. From a long-term perspective, we also indicated that we're working as an agency to bring consistency among our programs with regard to provider directory guidance. And the programs that immediately come to mind would be Medicare Advantage, Medicaid, and the Marketplace. In addition, we talked about the concept of exploring the idea of an online database that would allow for there to kind of be a hub, if you will, for providers to use and plans to use kind of a one-stop shop, if you will, that we feel as though would be a way to alleviate some of the burdens that we'll be talking about later on today. Subsequent to the call letter, we had the Medicare marketing guidelines, which I won't go into the details, but just kind of taking what the call letter said and putting it into our manual chapter guidance. And then there was a clarifying memo that came out just after the publishing of the Medicare marketing guidelines. So we're now going to take a look, turning to the panel, and as we met for this presentation and kind of brainstormed how we wanted to present, we identified some challenges, and we thought it would be helpful to kind of discuss some of these challenges. And then as we move into the more open discussion, I would encourage everyone else in attendance to provide your input as well. So I'd first like to turn to Deb to ask if she could maybe discuss a little bit about the first two bullets here. And I see these two bullets as kind of different sides of the same coin. Mm-hmm. On one hand, you have the possible burden to providers in multiple plans needing this information on a monthly basis, as well as the challenge for plans to contact the providers on a monthly basis. So Deb, would you talk about that a little bit?
Sure. So I think importantly we have to acknowledge first that there is an industry-wide challenge, not just for the plans, but for the providers as well, to maintain accurate and current provider directory data. Really represents an industry-wide challenge for both plans and providers. And if you think about the provider administrative burden, which is really a significant root cause of this challenge, we're asking the providers to maintain their data with multiple different plans, and in some cases many different plans, and we're all doing it slightly differently. So there are some long-term solutions that are in development, and I know there's several different groups, and Mark's going to talk about what AHIP's working on. We know CAQH is also working on some long-term solutions. There's other industry groups, including, again, both plans and providers that are working on some long-term solutions. I think we have to acknowledge that unless we all work together, plans and providers, to address that significant root cause of this issue, we're not going to be successful in achieving the goal of having accurate, current provider directory data. So that's the first challenge that we wanted to address, which we'll speak some more about. And then that does segue into the idea of monthly provider communications or provider contacts. on the surface, it sounds like monthly provider contacts might be a good way to resolve this issue. But when you think about the need to really address that root cause of the administrative provider burden, the idea of all of the plans, all of us every month contacting all of our providers, not only does that not reduce the administrative burden on the providers, but it's potentially going to increase the administrative burden on the providers in the short term. So I think we all have to acknowledge that and think through how we're going to address those concerns in the short term. I think the other key challenge with the concept of monthly provider communications is, again, what really constitutes a communication or a contact. And in our discussions and internally and in discussions with CMS, what we're really trying to do is think about a contact more broadly. What we really should be doing is looking at different ways to validate provider data, and contacting providers may not always be the most effective, efficient way to do that. So we have to think about that more broadly. I don't know if you have anything to add.
You know, I think from our perspective, we've been looking at it both from a short term, how can we meet the immediate need of the monthly outreach, but the challenge there is you've got providers that are going to be getting this outreach from multiple plans, so how do we streamline? And some of the industry work groups and initiatives can help to do that, so we're looking at vendors that maybe can do that, not only on behalf of us as a plan, but other plans to try to minimize that. But then from our perspective, because we offer multiple products on the exchanges, on the Medicaid side, and even for our group insurance business, provider directory accuracy is a challenge. So one of the key things we've done internally is open up the lines of communication between the different areas, share information about how we're trying to approach this important issue on the group side, on the individual side. And then you throw into the mix different requirements. For example, on the Medicaid side, there were proposed rules that talk about 3 business days to update the directory versus immediate update. On the individual side, the directories have to be in a machine-readable format, and so those may be things that may be coming down the pike on the MA side that we need to be prepared for. So having those open lines of communications to share ideas, see where there are synergies, where we can, even though there may not be a monthly outreach, does that make sense across other lines of business so that we can ultimately meet the needs of all of our constituents.
As a small plan, one of our issues is we have about 2,000 providers that we don't have email addresses for. And we wanted to do an email blast, which is easy for the thousands that we do have. So we've developed a postcard, a color postcard that we're going to send out asking for that, and some incentives with the offices. We have a pretty intimate relationship with a lot of our providers. And we have found that dealing with the office manager or the staff, sometimes we get a lot more information. And so we are thinking about doing something as basic as providing lunch from people that turn in their address to the whole office. We've done things like this before, and they really like these type of things. Same thing, staff internally. When time permits on a call, if they're talking to a provider, double checking their address, keeping track individually of each customer service rep and how many of those they achieve receiving, and same thing, there'll be some kind of prize for them as well. And we're just taking it small approaches like that at first.
Thank you guys, I appreciate that. Sherry, I don't know if you have any additional information with regard to implementing the guidance of real-time as it applies to the online directories.
The only thing that we can do simple changes that are made through the provider portal, the web, email, or phone call. We do those the same day. And they're loaded overnight, so it's kind of real time by the next day. The only problem we have with that is sometimes a change could require a new contract, a new tax ID number, credentialing. If they're going from a delegated entity to solo, it might take a little longer. So we're tossing around maybe putting some indication by that provider's name as he was listed to call for specific questions until that's finalized.
And Sherry, Rich, do you have anything to add?
Yeah, I think from the larger plan perspective, the real time, and when I say real time, I'm referring to overnight, is a challenge just because of the system infrastructure and the different products that we need to do our due diligence to make sure we're interpreting the change, applying if it's an address change to the correct physician, making sure we're updating it across all of our products. So it real time, such as overnight, obviously we want to get there, but right now it's going to take some work to figure out how we can consolidate this across all of our markets, across all of our products to get to that real time overnight change. But that is one of the big challenges we're dealing with as a plan.
Yeah, and I would just add, in our internal review and in discussions that we've had with others, one of the challenges that we've talked about related to the idea of real-time updates is the importance of balancing the speed with which you make those updates in your online directories with the need for some kind of quality review. So to just give you an example, an important fraud prevention tactic is to check the addresses to make sure that addresses are actually valid addresses. And if you don't build something like that in, you could potentially pass harmful information on to your members, onto beneficiaries. So we're really trying to take a balanced approach, and overnight may not work for us, an organization of our size, but what we're really looking at is could we maybe do it in 3 business days, which is consistent with the Medicaid guidance with built-in QA checks. And then the other thing that I want to acknowledge is it depends for a larger organization, it depends on how that update comes in. So if it comes in through the portal and we can build in an automated QA check and everything's there and it's all clean and complete, we probably can do it in 3 business days once we build that capability. But if it comes in another way and it requires some kind of intervention or research, or you have to check licensing or anything like that, that's obviously going to take a little longer.
Yeah, I would say from our perspective, 3 business days is certainly within line of what my vision of real time would be. And I would also say that we have received some questions with regard to, further defining what real time is. And I think we as an agency understand that there's differences in how plans per size, per region, per, lots of different factors can accommodate for that. So it is vague, and I understand the frustration with vague, but we felt as though that was the much better place to be in trying to incorporate some of the flexibility and not kind of hem it into something that wouldn't be doable for the entire industry. Rich, just coming to the last point here, and you did touch on this a little bit, but could you talk a little more about implementing the multiple program requests?
Yes, so we've been meeting on a regular basis with our individual folks to talk about the requirements we have for monthly outreach and some of the approaches we're taking versus some of their requirements on they have monthly updates. And we're part of industry efforts to look at vendor solutions for that. We're sharing that information across the different lines of business. We're looking at other options, and Deb talked about and Sherry talked about, are there website portals that we can utilize to update that information? Are there things as simple as reviewing returned mail and reviewing that against the information in our databases to update it? So really sharing information, sharing ideas, getting a better understanding of the other requirements for the other lines of business, because again, I refer to the machine readable format. If I were a betting man, that may be coming down the pike for our line of business as well. So that's something we want to know how we're accommodating that requirement on other lines of business so that we can be in the best position to implement change there. So again, communication for the plans that do offer multiple lines of business so that you understand not only the requirements among the other lines, but what your other lines in-house are doing if you've got different owners for the different products.
Great. Deb, Sherry, anything to add to that?
I would just add to the communication internally. I think also equally important is communication with CMS, other regulators, and other stakeholders. Our experience has been when you do look broadly across all of the different rules, you may see something like 3 business days in the Medicaid rule that makes more sense to you compared to what may be in a different rule. And I think that feedback and sharing that feedback with CMS and other regulators, I'm hoping has been helpful, and it's helpful for us to have that dialogue with you and other stakeholders, provider groups, et cetera.
You take advantage of the comment period.
Yeah.
The Medicaid rules were just out for comments, and I know as a plan we did submit comments. So
that's good. That's very helpful. So what we really talked about in this brief discussion was a lot of the short-term need to address the new requirements. I now want to turn it over to Mark to talk a little bit about the longer term, and longer term is kind of a flexible way to say it, but looking at a more global approach. Mark?
Thank you. It's a pleasure to be here. So I think as Deb, Rich, and Sherry clearly illustrate, this is an industry-wide issue, and at AHIP we recognize that, and for some time now we've been having discussions with plans and with provider and consumer groups about ways we may be able to come up with an industry-wide solution. In all of these discussions, some really core principles have emerged, which I think are very much consistent with what the panelists have already said. First of all, and I think it's probably obvious, but it's worth saying, that all of the stakeholders, the plans, the providers, and the consumers agree that it's very important to have accurate provider directories. And I know CMS does as well. Second, provider engagement is a critical part of this. No matter what sort of system you can create, the providers ultimately are the sources of the data. They need to be willing to provide and able to provide that information in a timely way and in an accurate way. Third, to get provider engagement, and there needs to be an approach that alleviates administrative burden. Deb was talking about some of those issues, and what became clear to us is that what providers would really like, if possible, is have a single place where they could provide their information, that it would cover all the plans that they accept. It would apply to all of the different programs that those plans are in. The fewer number of places where they need to update information and the most consistent way possible is the best way to get that provider engagement, which is really critical. Fourth point, and I think Rich got to this as well, consistency across programs is really important for systems purposes, for operations purposes, communications purposes. For all of those reasons, the more that program requirements differ, the harder it is to have consistent and accurate information and updated timely. A fifth point that emerged in talking to consumer groups is that what we heard very loudly and clearly was very simple, is they want to be able to access basic demographic information. Not a lot of bells and whistles, not asking for a lot, but just the basics. That's what they care about. The last point I wanted to mention is, as we've been exploring, at least in terms of principles that have emerged, as we've explored possibilities, it became very, very clear that if you're going to have an industry-wide solution, you first have to start from the proposition that there are lots of ideas and ways out there to collect and update directory data. You've got some vendors, for example, that are really focused on providers and consumers and have direct-to-consumer tools. Then you've got providers that their main business plan is focused on plans and developing tools that the plans would then use in working with providers. So there's a whole spectrum between those as well. Based on all the input that we got from all the stakeholders, we concluded that over the longer term, to have a sustainable and effective, accurate directory system, if you will, it really requires a central database of provider information, at least at the state level, and that's going to be the best way to ensure accurate and timely updates to data, and importantly, again, to get provider engagement. And to determine the best way, given there's so much variety out there, what we've decided to do is launch a pilot. And the pilot is going to evaluate different vendor models to see which produces the highest level of engagement and therefore timely and accurate updates to information. We plan to conduct the pilot in multiple states because we want to see if there are different geographic characteristics that might also have an effect on this issue. The pilot would cover all provider types, cut across multiple lines of business. We are currently in active discussions with vendors, and I expect very soon we will be able to make a decision, we'll make a decision about the vendors that we're going to use and the states that we're going to experiment in. We intend to have the pilot start in the fourth quarter, and we envision it running for 6 months. At that point, we will engage in a very comprehensive and rigorous evaluation of what we received. but also do it very quickly, because we expect that this pilot will inform a national approach that could be used, and we are aiming to have it ready for 2017. So what we are doing at AHIP is we're really trying to facilitate a market-based approach that's going to bring plans and providers together, and so that they can share information in the most efficient way possible. We really do believe that everybody up here and people probably that are sitting here and listening, they all have the same goal. And we really do think that to have a sustainable long-term approach, that getting all of the key stakeholders to buy into this sort of approach is the best way to move forward.
Thanks, Mark. We really appreciate that. Using our discussion that we just had as kind of a springboard, I wanted to now open it up to talk a little bit more and engage the audience to give you the opportunity to provide us some additional information or detail. So I would say my first question is, are there any challenges, and I know that we went through these relatively quickly, but are there any challenges that you feel as though were not really discussed? If you think about your top 5, were the 4 that we discussed in that top 5, or are there other challenges that weren't addressed? Take that as that they were somewhat addressed.
Those are tough enough, perhaps?
I did want to talk to the panel a little bit about what I would consider to be vehicles of communication. And when we think about different ways to both contact the provider and to have the provider contact us, do you find that there's any specific type of communication that's more effective or less effective? And does that change by the region or the area or the provider type?
I think what we're finding is that different provider types have different preferences. So if you think about a smaller practice versus a larger group versus a delegated group, that they do have different preferences. And someone in a session earlier was saying you sort of have to figure out how to work with them. We have a preference. Our preference would be that the communication happen electronically, because we think that that's going to be the easiest, fastest way to kind of get it to flow through to the directory. But I think we also want to acknowledge that our providers have preferences, and it's important to work with them with the understanding that depending on how they work with us, it may take a little longer.
Yeah, we've traditionally, our network operations folks in the field who work very closely with our provider groups will conduct that ongoing outreach. Now, the challenge there is, can we prove that's happening? Because those are face-to-face conversations, and they take the information down. So we're also looking at more automated electronic vehicles for the monthly outreach. Also looking at, can we update our provider portal to allow providers to come to us proactively in an electronic format. Some of the industry groups may get 95% of our providers. So are there other things we can do internally to accommodate the ancillaries, such as email blasts on a monthly basis? Then you've got the challenge Sherry spoke about. Do we have accurate email addresses? So whatever we do, we want to do in an automated fashion. I don't know if having folks on the phone every month calling the provider office will be provider friendly, because they will not want to be taking those phone calls. So as we can get creative industry-wide to make it a one-stop shop for the provider to communicate back to the industry, I think is the ultimate goal. And in the interim, we have to get creative on how we're, as a plan, outreaching to our provider.
Sherry, anything to add to that?
No, it was just kind of funny. We tried having a couple people call for email addresses just to see while we were working on our postcard. And my admin came in and she said, they said they're not interested. I said, well, it's not a matter of being interested. I said, call them, try the next ones and tell them that in compliance with their contract, they need to provide us with that information. She came in, she goes, it worked. But they were just saying, no, thank you, we're not interested. So.
I think that's a key point. I'm sorry, Mark. It is also how you ask the question, which is something that I think we've learned. How you outreach and what you say when you're outreaching drives a different response rate with your providers, and making it clear that they are required to respond, but also explaining what's in it for them, I think has been an important lesson learned.
I think Sherry's point is also important to state the obvious, which is perfection. It might be a goal, but it's never going to be attainable. So hopefully CMS recognizes that.
Sounds like being put on the spot, right? Just to kind of continue on to that part of the conversation, do you see a difference between providers that are what I would consider to be active providers versus less active providers as far as how many of your members they're treating? Do you see a difference in the communication or the need for communication?
Well, I think there's there's a different level of engagement with a provider that's more actively involved with us where we have more membership. Certainly, I would say we see a difference there, not just in this respect, but in many ways in how they engage with us on STARS and lots of other aspects as well.
Yeah, I would agree. You're going to have your fully engaged providers that it's not going to be a problem. They're going to be very responsive, and the information is probably up to date today versus your unresponsive ones. And this is going to be an evolving process where as we learn more about our providers' habits and maybe different habits in different markets, we'll have to make updates to, okay, well, we know we have to focus maybe more, follow up the letters with outbound calls to these providers. So it'll be an iterative process as we develop our solutions.
Great. I think we have time for one more question, and I really want to ask the panelists as well as, again, the audience, if you see any other opportunities for collaboration, and whether that's collaboration internally within CMS, collaboration across the MA and insurance industry. Do you see any opportunities for that? And it's a very broad question.
I mean, I know I spoke a little bit about this, but if we could get just consistency amongst the different products that CMS has oversight for, Medicaid, the exchange business, Medicare, that will not only benefit the plans, but the providers, so that a provider that may be used to dealing on the individual side, well, that's not a requirement. Why are you reaching out to me monthly? Well, for Medicare it is. So I think that consistency will be very helpful for the industry.
Good to know. Sherry, anything?
We actually, on our other lines of business right now, are reviewing Ohio's new rule for provider directories. Oh, okay. So they have one in the state of Ohio as well. The timeframes are a lot more lenient, but you still have to make sure that you're, in guidance with everybody that's asking. So our provider department covers all the lines of business. So trying to make one thing work for everybody.
Great. Mark, anything?
No, I think they spoke very well.
Okay, appreciate it. I think that's all the time we have left. Oh, I apologize.
Oh,
yes.
Thank you. Great information so far. My question is more of a logistical question. So I understand the online provider directories need to be updated almost on a real-time basis, but has there been any discussion or consensus about how frequently the hard copy should be updated? I understand there's information that says you could provide an addenda, but that online directory could be updated several times a day, possibly, if it's real time. But how frequently are you updating that addenda to the hard copy directory? Because you want them to be consistent.
Yeah, it's a good question, and it's one that we've heard definitely loud and clear. It's that balance of it needs to be updated regularly, and I think the addendums are a way to kind of save the trees, if you will. I would say that at minimum on a monthly basis, you should be looking to ensure that the provider directory, hard copy that is accurate for those that are receiving it.
Thank you.
Sure.
All right, that brings us to the end of this session. So I would like to thank our panel for sharing their experiences with us today. And I also wanted to apologize again for the power outage that we experienced earlier, and to let our viewing audience know that we are doing our best to get back on track with the agenda that was laid out today. With that said, we are scheduled to go for a break, and we still are going to take that break, but we are going to skinny it down to 5 minutes versus 15. So it is currently 2:05. If you could please be back at 2:10, we will continue. Thank you.
somebody has the clicker. Does someone have the clicker down there? You have the clicker? There it is, right over there. There's more. There's some more. Guess we don't want to keep that up there in the back here. You can move it in, but yeah, it's just a small screen. Oh, it is pretty small. I guess they had it turned. Surprised they were doing a break. They're running behind. That must be Danielle. Not a lot. No.
Hi, Mark. I know.
Welcome back, everyone. And also welcome back to those that are hanging in with us on the webcast. Thank you, everyone, for being back on time. It was a shortened break, so we appreciate it. Remember to send in any questions you may have for any of the speakers today, as we will have that open Q&A session at the end of the day. So please send in any questions you have. It is not too late. Our next session involves a number of subject matter experts that will help you to get ready for 2016. We will start off with a discussion on prescriber enrollment with Lisa Thorpe, Alicia Banks, and Rebecca Randall. We will then hear from Patty Helpenstein on good cause process, and Jennifer Smith will close us out with a discussion on 2016 program audits. Please help me to welcome our panel today.
Hi, I'm Lisa Thorpe, and I'm here to talk about the prescriber enrollment requirement for Part D. Hopefully most are aware that beginning June 1st, 2016, in order for a Part D beneficiary to receive coverage for a drug, the prescriber has to be enrolled in Medicare and improved status or be validly opted out of Medicare, with very few exceptions. This includes dentists, physicians, other eligible health professionals. So just for a reminder, for the reason for the requirement is it's an important additional tool for CMS's efforts to promote quality and combat fraud and abuse in the Part D program. There's been reports of unqualified physicians prescribing Part D drugs, even physicians with suspended licenses, physicians prescribing inordinate amounts of drugs. So the enrollment process that prescribers go through allows CMS to verify their credentials. These are the two pertinent regulations. We presented on the first part of the regulation last year, and so now we're going to focus on the second part, which was finalized in May of this past year. It's an interim final rule. So the interim final rule sets up two exceptions to the requirement. The first is for other authorized prescribers, and I'll get to that more in a moment. And the second is that the interim final rule requires Part D sponsors to first cover a provisional supply of a drug before denying future claims on the basis that the prescriber is not enrolled or opted out. We've had meetings with stakeholders and various input, and we've listened to that, and so the interim final rule reflects the input from interested parties. Both of these exceptions are designed to provide continuity of care for Medicare Part D beneficiaries. And just a small note, prescribers still have to have an active and valid NPI for a prescription from an other authorized prescriber or provisional supply to be covered, because obviously they're not going to be in our PICO system as enrolled. This is the definition of other authorized prescribers. I think we're a little short of time, so I'm not going to read that. But the gist of it is that in many states, there are providers who can prescribe but aren't eligible under the Medicare statute to enroll. And so we realized that we were going to need to provide an exemption for those types of professionals. So for instance, pharmacists are allowed to write and modify prescriptions, certain prescriptions in certain circumstances. However, the statute does not allow pharmacists as a type of provider who can enroll in Medicare at this time or opt out. And so this exception means that Part D beneficiaries can continue to receive coverage for prescriptions written by pharmacists as allowed by state law without enrolling or opting out of Medicare. We've published a Medicare provider enrollment eligibility reference table to assist in identifying these various categories, and thus far we've only identified pharmacists and naturopaths as providers who cannot enroll but may be eligible to prescribe in states. Pharmacists account for the vast majority of those prescriptions. So for provisional supply, the interim final rule requires, as I said before, a sponsor to first cover a supply of 3 months before denying future claims. The requirements of the Part D program still apply to the coverage. It's not like all of the other utilization management or other requirements would be lifted for a provisional supply. It just means that the enrollment or opt-out requirement would be lifted. And of course, the prescription always has to be allowed by applicable law. The interim final rule also requires individual written notice to be sent by the sponsor to the beneficiary when that provisional supply is covered for the first time, to let them know that their prescriber is not enrolled or opted out, and that they need to get enrolled in order for the prescription to continue to be covered. We said in the interim final rule that we would provide a notice for Part D sponsors to use, and we're working on that. And the interim final rule also requires reasonable efforts to be made by sponsors to notify the prescriber when that provisional supply is covered. So the provisional supply is, again, intended to give the prescriber enough time to enroll. And it also applies when the provider is disenrolled, so that the beneficiary has time to find another prescriber if they wish to continue Part D coverage for their drug. We've issued multiple guidance documents since the IFC was published in May, and we just want to make sure everyone has seen all of them. The first one was June 1st, and that is what delayed enforcement until June 1st, 2016. It also encouraged Part D sponsors to begin conducting their own prescriber outreach no later than January 1st. And we provided a draft sample for that purpose to stakeholder associations to review at the end of July, and we're reviewing comments and should be issuing that very shortly. We also said in the guidance that enrollee outreach would begin no earlier than April 1st, and we wanted to do some continuing prescriber enrollment trends and analysis of the effectiveness of that, and that we would speak to that topic again by the fourth quarter 2015. Another guidance document was issued on June 9th. This is basically the PDE guidance. And it lays out what Part D sponsors will have to do with their PDEs beginning June 1st. In general, Part D sponsors will be telling CMS whether the PDE should be evaluated against PCOS, meaning this is a PDE where the prescriber should be enrolled or opted out, or should the PDE be evaluated against NPES because it's a provisional supply or it's a pharmacist, so we would only be checking MPI status and NPES for that. I would encourage everyone to read this again because we get a lot of questions on PDEs, and we really believe that most of them are answered in this guidance. Some of the comments on the interim final rule about PDEs, it was issued very shortly after the interim final rule, but we think we've answered just about all of the questions there. So that would be an important one to go back and look at. And then June 10th guidance, this was guidance for MA organizations, and it requests that organizations that offer Part D prescription coverage confirm that their providers are eligible to furnish Part D prescriptions. Medicare, it also notes that Medicare payment can't be made directly or indirectly for services provided by an opt-out physician, so that's not really an option for a provider who's contracted with a Medicare Advantage plan. And then just to make sure everyone's aware of the websites, there's 2 different websites, one for Part D sponsors and PBMs, it's listed there. Another one that's the Center for Program Integrity manages for providers. And just please keep checking the websites for additional updates. Thank you.
So we understand that minimal enrollee impact is key to the success of this initiative. So in our outreach activities, we've communicated the importance of these requirements and the downstream impacts if the prescribers don't comply. And we're also monitoring and tracking the enrollment rate. So we want to determine who is enrolled and who is still required to enroll that hasn't done so already. And we want to be able to target those prescribers who have not enrolled to get them enrolled before we enforce these requirements. So when we assessed this data back in January, we determined that there were about 434,000 prescribers who had not enrolled, and this includes anyone who had previously enrolled but were currently inactive in our system. And so we also take into account any new prescribers that we've identified based on the claims data, and then we exclude any prescribers who are currently deceased or revoked in our system, and those who have come into compliance. So there was about 42,000 that we can determine have come into compliance since we started this initiative. So our end goal, or where we are right now, or as of July, there's still about 398,000 prescribers who still need to enroll. So we're also monitoring the top 10 impacted specialties so that we can target our outreach efforts to those who still need to come into compliance. And right now we're showing that our dental providers are the highest impacted providers, followed by our students, which are the interns and residents, and our nurse practitioners. And we've included pharmacists in this table, but as Lisa indicated, they're excluded from the enrollment requirements, so they don't need to enroll to meet these requirements. And then we're also assessing the top 10 states that are impacted. So we've identified that California, New York, Florida, and Texas are the top impacted states that house those providers or prescribers who still need to comply.
All right, thank you. So before diving into the outreach currently underway, I just wanted to provide an overview of the strategy that we came up with to reach our objectives. Everything we are doing is data-driven, so we are constantly stratifying and segmenting the groups of unenrolled prescribers by prescription drug events, specialties, and geographic location. As Alicia just pointed out, to name a few, the geographic hotspots include California, New York, Texas, and Florida, and the specialties include dentists, students, and nurse practitioners, to name a few. I'm not going to go through all of this because I know that we are pressed for time, but we aim to convene multiple key stakeholder groups to establish networks, coordination, and information sharing. We did kind of a landscape analysis to see like our current website presence, where we were currently, and what we needed to do to heavily improve to make sure that what we were asking prescribers to do, they could actually complete it with going to the properties that we currently have. And then finally, we wanted to engage the market with our various strategies, so I'll get into that. So the first thing was the website redesign. So we took one look at this and knew this needed to be redesigned. You know, we needed to make sure that we were, when people arrived there, that what we were asking them to do, they could actually do, the calls to action, plain language, really get them to enroll, check their enrollment status, etc. So the first step we did was we fast-tracked a website redesign of the Part D prescriber enrollment. Now, by no means is this perfect, but it's a big step forward in terms of getting the critical information that's necessary to enroll in Medicare up on our website. So as you can see, we have three main areas, which is check your enrollment status, enroll to prescribe, learn more about the prescriber enrollment regulation, as well as a call out for pharmacists, because we really wanted to make sure that they understood how this affected them. Another mechanism that we were using was digital advertising. And again, we were using paid digital ads and targeting the largest prescription drug event, non-compliant specialties, with rule awareness messaging across three verticals: prescriber-viewed websites, which are sites such as specific media, e-healthcare, professional specialist organizations such as ADA.org, as well as Google search. So if you went to google.com and typed in a keyword that we're targeting, you're going to see an ad, and hopefully someone will click it and they'll be taken to the Part D prescriber enrollment website. So results as of August 26, 2015, we've had 12 million ad impressions. So what that means is that the ad actually appeared across one of those three verticals. From those impressions, 28,197 visits to the Part D page have been taken from the ads. So that means they clicked on the ad and they went to the Part D prescriber enrollment. And then we consider acquisitions two things. Either they go to the PACOS website, which is the electronic way to enroll, or they can go to the paper application and send it to their Mac. So we've had 1,945 visits to the PAYCOS website and 290 downloads of the paper application. I do want to point out that this does not include, so if someone clicks the ad and they go to the Part D prescriber enrollment website, and then they leave, but they come back and go to PAYCOS or go to the paper application, these analytics are not capturing that. So it all has to be done in sequential order for our analytics to reflect that. So just to note that. One other thing just about the digital advertising, we launched this back in the middle of June, and we started out doing just rule awareness messaging. We are now switching that in early fall to deadline-driven messaging to really encourage and motivate people to enroll immediately. Another thing we've been doing is specialty events. So we have been meeting with various associations and regional groups to build awareness of the Part D prescriber enrollment requirements. We wanted to better understand any barriers preventing enrollment and potential consequences of non-enrollment. We wanted to establish the networks and a way for information sharing to happen. So I can't go into all of the associations that we met with because it would just be too many, but here are a sampling. We're also really beefing up our conference presence so that we can really make sure, again, guide and inform and encourage prescribers to enroll there on site, or at least give them the necessary information so that they complete and take the necessary action. Other things we've been doing, we've had a lot of email marketing campaigns. So we have been using email addresses of prescribers found in MPES, but who have not yet enrolled in PAYCOS, to do a direct email campaign urging them to take action and enroll in Medicare. We are planning to do another second campaign using this methodology with a more deadline-driven messaging campaign. We are in the process of doing a Medscape email. It's set to be released in early October, and this is again reminding prescribers to enroll, and will really hit upon dentists and nurse practitioner specialty groups. As Lisa mentioned, we are drafting a sample letter for the health plans to use for prescriber enrollment outreach, and we've updated all of our customer service scripts so that can be taken care of. We're also doing a lot of social media listening. We want to take this information and learn what's the current sentiment around the Part D prescriber enrollment. Are there any pain points or perceived barriers that people are having problems with enrolling that we can address? What information or materials can CMS provide to various key stakeholder groups or prescribers in general to aid them in making this a fluid and easy process for them? Some of the things that we keep hearing is that there's a general belief that the enrollment process is overly complex and too time-consuming. It results in some prescribers paying middlemen to execute their enrollment at a very high cost to them. So one of the ways that we tried to address this was we created a video tutorial, which is available at go.cms.gov/video tutorial. And it uses screen capturing technology to show and narrate the step-by-step process of enrolling in PAYCOS to the viewer. And it was published on the CMS YouTube on July 30th and has currently been viewed over 550 times. But we really want to show that it's not as complicated as people are perceiving it to be. Some outreach resources that we wanted to make sure everyone in this room was aware of are, as I mentioned, the video tutorial, the how to enroll how-to guide, the enrollment file on data.cms.gov, obviously the Part D prescriber enrollment website that we just saw, the Part D prescriber enrollment MAC list that is customized for this initiative, and the 2 email addresses, providerenrollment@cms.hhs.gov and the Part D policy at cms.hhs.gov. Going forward, obviously, we saw the numbers, so we're rethinking our strategy. We really want to utilize continuing medical education to entice more prescribers to successfully enroll in Medicare. We want to target the top prescribers with personalized outreach via phone and email and maintain that communication until we've guided them to successful enrollment. We're looking at creating toolkits both for associations and our regional offices so that they can be used to market this and extend the reach and capacity of our messaging, get the word out, and also for pitching efforts to state medical organizations or licensing boards and media. We want to capitalize on other initiatives such as e-prescribing, whether it's an auto message reminding them of the deadline for this initiative. And then we're also planning an enrollment help walkthrough webinar with question and answer. So with that, I will hand it over.
Okay, so we're going to talk a little bit about the good cause processes. Specifically, at the spring conference, we talked about the fact that CMS will be delegating the good cause processes to plans when they disenroll someone for non-payment of plan premiums. Specifically, that's for MA, Part D, and cost plans. Again, there are a couple important things to know before I get into the meat of the presentation today. And that is that, again, anyone disenrolled for non-payment of Part D IRMA, the process is not changing. It will remain the same. And plans will be assuming this responsibility for disenrollments that are effective on January 1st, 2016, which means it doesn't impact the AEP. It really is about, based on when the person's disenrollment is effective. So we have about 4 months before you're going to start receiving any requests for good cause. That said, if someone is disenrolled with a effective date of 12/1, as part of the normal process, the individual has 60 days to call. So any disenrollment 12/1 will go through the current process, even if, for the 30 days of the overlap, they have that extra time that carries over to request that good cause. They will go through 800 number through CMS, but any disenrollment effective January 1st, those requests will be coming directly to the plan to effectuate. Today's presentation is really going to be about explaining what constitutes good cause. We've received a lot of questions. What would be a favorable determination? What would be unfavorable? How does it work? So today's session is really about outlining those examples and then doing a few case studies. I have about 5 of them in our presentation. I do not have that much time to speak, so I'll get through as many as I can, and then there's still information in the slides if we can't get through all of them. So an important point is that good cause exists when the person who's paying the premiums, typically it's the member, might be an authorized representative, they're unable to pay the premiums within the plan's grace period, and the reason that they couldn't pay is based on an uncontrollable or unforeseen circumstance that, bottom line, they couldn't control anything, it happened to them, it caused them to miss the payment and not be able to arrange for payment timely within the plan's grace period. We expect that this occurs rarely across the board. However, in guidance, we have outlined some examples of what we think could constitute good cause and examples that wouldn't. So I want to go through what some of those are. For favorable determination examples, we would expect that a serious illness, institutionalization, hospitalization for a significant portion of the grace period would occur. So an individual was unexpectedly hospitalized for a month and a half out of the plan's 2-month grace period. They're incapacitated. It would be reasonable that they might not be able to pay their premiums timely or make arrangements. Similarly, if there's a recent death of a spouse, immediate family member, caregiver, or someone living in the household. So that could be obviously the person who's paying the premiums. If it's a caregiver, it's the member, the spouse of the member, whatever it might be. For other things that occur during the plan's grace period, and I want to go through these in a little bit more detail. Prolonged illness that is not chronic in nature. So, for example, someone becomes ill with pneumonia and is laid up for 2 months out of the plan's 2-month grace period. I guess in contrast, someone who has diabetes that's a chronic condition and is maintaining that would not count. it's expected that they would be able to handle their chronic condition. However, the second sub-bullet we have is if the person has a chronic condition and there's a serious complication. So, for example, someone with diabetes recently develops ESRD, throws you for a complete loop. Everything's changing, hard to, manage what's going on at that time period. That might constitute good cause. Or a rapid deterioration of a member's health or the health of the spouse, the person paying the premiums, whoever it may be. That arena is really, it can encompass a number of different things, but I think in that arena is where you might get cases of a son calling because his parent has rapid deterioration due to Alzheimer's or something to that effect. Some other items would be if the home is severely damaged by fire or a natural disaster or some other event that is preventing their timely payment, or an extreme weather-related public safety event that is declared as a federal or state level of emergency. And for that particular item, it's at any point in the grace period. There's no duration requirement. If there's been something that is extreme and it has the federal or state declared emergency, then they could meet the good cause criteria. Some examples of unfavorable determinations would be simply indicating that they never received their bill. They didn't report a change in address. They were on vacation, out of town, whatever it may be. In that situation, it's a controllable event. The individual could have made arrangements or paid timely. There was nothing that directly impacted them that prevented them from being able to make timely payment. Another example would be the individual, if they have an authorized rep or someone paying their bills and that person just didn't pay timely. Obviously, the expectation is, when someone joins the plan that they're paying the premiums on time. And one other item is the person couldn't afford to pay the premiums. So inability to being able to afford to pay is not the same thing as being prevented from being able to pay premiums because of an uncontrollable event. Likewise, if someone didn't understand, they would be disenrolled for non-payment. Of course, if the plan disenrolls for non-payment, it's included in the EOC, and they would have notification. Or if there is no other circumstance but the person needs prescription drugs. That's not a reason for why they couldn't pay their premiums timely. So let's get into some case studies. I'll just read this one through. Mr. Smith was disenrolled on August 31st, 2015, following the plan's 2-month grace period. He states that he recently was diagnosed with cancer and has been in the hospital receiving treatment since July 10th. He was released on September 3rd and just found out he was disenrolled. So what's the determination? Favorable or unfavorable? In this case, yes, favorable. And why is it the answer? Was it that the event was unexpected, recently diagnosed with cancer, a serious illness? Or was it the event was unexpected, he was hospitalized? Or C, the event was unexpected, hospitalization, and was in the hospital for the majority of the grace period? And the answer is C. So he had been in the hospital for a very long duration of the plan's grace period and unable to make payment. So let's look at case study 2. Mrs. Culpepper was disenrolled on May 31st, 2015, following the plan's 2-month grace period. She states that her husband has diabetes, recently had kidney failure, and started dialysis in May. Because she was taking care of him, she was unable to pay her premiums on time. Favorable or unfavorable? Favorable. And why is this the answer? Complication was a chronic condition that occurred during the grace period. The wife was a caregiver. It's reasonable that she couldn't have made timely payment due to the seriousness of his condition, or all of the above. And the answer is D, all of the above. Oops. I don't know what happened there. Sorry about that. Okay. Case study 3, Mr. Long was disenrolled on April 30th, 2015, following the plan's 3-month grace period. He states that a kitchen pipe broke and it flooded his basement of his home. He had to make expensive repairs, and he wasn't able to pay his premiums. Favorable or unfavorable? Unfavorable. And why? There was no declared state of emergency. The flooding didn't destroy his home. The flooding in his basement didn't prevent him from being able to make his payments, or he wasn't able to afford the premiums, and that's irrelevant. The answer to this is C. Because his home wasn't severely damaged, it's reasonable to expect that he had the ability to pay his premiums timely, and the expenses to repair his basement and kitchen pipe are not a factor in making the good cause determination. Okay, case study 4. Mrs. Sanchez was disenrolled on April 30th, 2015, following a plan's 2-month grace period. She states that her husband took care of their bills, but he passed away this February. She doesn't have any family to help her, and she needs coverage back because she requires heart medication. Is this favorable or unfavorable? This is favorable. And why is it favorable? She didn't understand the ramifications for not paying because her husband paid the bills. Her husband died relatively close in time to the plan's grace period, and this was unexpected. Or she needs medications. And it's B. It's because her husband died recently. It's reasonable to expect that she was in mourning. She wasn't able to pay her premiums timely. Now, I do want to make an extra note here that it's important in this case for plans to really take this type of opportunity to offer for an individual like this who says she's new to this. She's never had to pay bills before. She's not really sure what to do in handling the finances. To really offer, if your plan provides electronic scheduled payments, auto pay, whatever it might be, so that she doesn't find herself at risk for disenrollment again in the future. It's not a requirement, but we would certainly suggest it to help that particular member. Our last case, case 5. Mr. Green was disenrolled on July 31st, 2015, following the plan's 3-month grace period. He states he got bills and warning letters from the plan, but didn't pay his premiums because he requested premium withhold when he enrolled. He states that the disenrollment was a mistake. So what should the plan do? Do you issue a good cause determination? Do you investigate for plan error? Or do you reinstate because there is an allegation of plan error? This is a little harder. In this case, it's B. You want to investigate first if there's plan error. So let's say in this case, the plan checks the records, finds there's no error on their part. They sent the notification to the right address. As part of the delay, like let's say in the premium withholding, it didn't apply as soon as the enrollment began, and the plan followed what we already have in guidance. It says notify the individual, tell them they're required to pay or they might be disenrolled. And let's say all of that happened. So now you need to look at that case again for a favorable or unfavorable determination. So what would your determination be? In this case, it's unfavorable. So obviously the plan has given the notification of the individual's responsibility to pay the premiums, and there is no circumstance that was unexpected that prevented him from paying timely. Okay, so a little bit more information. We have put out the actual guidance. It went out, I believe, a week ago today. It's up on our websites, which are listed here. And I do want to highlight that we outlined specifically the processes for both plans as well as the process continued for Part D IRMA disenrollments. We've actually created 2 new subsections to separate them. And we've added an Appendix 4 that provides about 7 examples for favorable and 7 examples for unfavorable determinations to try to help plans understand and help make those types of decisions. And of course, we'll be looking to obtain additional feedback as we transition, and we'll be hoping to hear from you and hear some of your lessons learned as well as you go through the process.
Good afternoon. So I'm Jennifer Smith. I'm going to talk a little bit about 2016 program audits, but before I do, I see a lot of familiar faces from our June Audit and Oversight Conference, so I wanted to update everybody a little bit about the status of the 2015 audit protocols before I go into 2016. So when we had that June conference, we talked about the feedback that we were getting from the industry related to largely record layouts and some errors that organizations thought there might be in the way we were requesting some of the data, specifically around our appeals and grievances audit protocols. We have updated many of the record layouts in those protocols, as well as made some additional changes, which I'd like to talk about just briefly. One, we've deleted some fields that were extraneous or were included in record layouts in error. We've put headers on each of the record layouts and indicated what data should be included, what data should be excluded. We've added additional information in all of the data dictionaries to explain specifically what each field means and what we're requesting. We've also clarified how certain data should be reported, whether it's by request receipt date, decision issue date, et cetera. And one of the, as we were making these changes, I think we were also conducting 2015 audits and getting some experience and additional feedback from the industry as well as from our auditors about some of the new processes that we had put into those 2015 audit protocols. And so we've made some additional changes beyond what we discussed with you all in June that I wanted to highlight. So, for example, one of the things that we were doing in 2015 is we really formalized a lot of our processes around beneficiary impact analyses and how we were asking for that information, both during the audit and before the audit started. In addition, we provided a lot of additional information about how plans are to report self-identified and self-disclosed issues. Just as a reminder to everyone, a self-disclosed issue is one that your organization identified and disclosed to your account manager prior to receipt of an audit start notice. What we consider a self-identified issue is an issue that you may or may not have been aware of before you got your audit start notice, but you have not previously disclosed to CMS. And we were requesting beneficiary impact analysis, which we call BIA for short, even on all of those self-identified and self-disclosed issues prior to the start of your audit, in the hopes that we could sample around or confirm correction of some of those issues during the audit. It turns out that's a really difficult thing to operationalize. So we're not going to be doing that anymore. We're not going to ask you for BIA. We're still going to ask you for self-identified and self-disclosed issues, but you'll see when we repost these audit protocols that we will no longer be asking you for that pre-audit BIA moving forward. One of the other things that we will be doing is we have kind of backed off a little bit or given organizations a little bit of a grace period with the new policy on universe resubmission. We had put in a policy that if you could not get us valid and accurate universes within 3 submissions, we would kind of call it quits at that point, and you would be cited every condition that we were not able to confirm during the audit. So, for example, largely that was around timeliness. If we weren't able to conduct a universe timeliness test, then you would get every timeliness condition, and those would be cited at an ICAR level. Moving forward, in 2016, I'll go over it a little bit more, but we're going to be updating that policy. So, just going through that, and in that second background bullet, I just want to apologize. They have not been reposted yet. We do hope to repost them shortly as they are in the final stages of clearance, and they'll get reposted to our website. We will make sure to issue an HPMS notice so that everyone knows when those updated 2015 protocols are out on the web. And one other thing by way of 2015 that I would just like to make everybody aware of, our last 2 audit start notices go out on Monday. So if you haven't heard from us by Monday, you're in the clear until 2016. Okay, so what are we going to audit in 2016? What are we going to focus on? So the core protocols are all back. We'll be looking at formulary administration, coverage determination, appeals and grievances in Part D, organization determinations, appeals and grievances in Part C, compliance program effectiveness, and our SNP model of care. We had originally proposed to pilot a medication therapy management and a provider network adequacy protocol in 2015. They are still under development. MTM, I will tell you, is further along, but because of the lateness in the audit season, obviously, we will be instead piloting them in 2016. So I know people must wonder what takes so long to develop these protocols, but as many of you have heard me say multiple times before, we try really hard to make sure that we are developing a protocol that is outcome-based, that is not overly burdensome to all of you, and that is going to fairly and accurately assess your performance and is tied directly to known and clear requirements in our guidance. So one example is, with provider network adequacy, the easy way to go would be to say, regardless of your organization size, you have to submit 100% of your HSD tables to us, and we will determine after the fact what portion of that network we're going to evaluate. Well, for some of you out there, that would be an incredibly burdensome request. And so I don't think, and it's also not something that we would actually be able to complete during an audit period. So I think it's more important that CMS figure out and understand how we can scale that request based on an organization size. A smaller organization, it might be completely feasible to have you load your HSD tables, if you're operating in 3 counties and you have 1 H contract. If you have 50 H contracts and you're operating in 3,000 counties, maybe we would just have you submit some subset of those counties. And so those are the types of issues that we're grappling with in trying to kind of make this a reasonable approach in how we're going to audit you. So what it will mean, some of you have heard me talk about this before, when we say we're going to pilot a protocol, what does that mean? It means that if you are the lucky participant in our pilot audit process, that you do not get a score on that protocol that first year, you get a bye. We will tell you your results without a score in your draft audit report, but the results will not appear in your final audit report and they're not going to go towards your score. So and then we will come to you and ask you for your honest feedback about how you think the audit, that portion of the audit went. I mean, we're going to ask you for your feedback on the whole audit, but in particular, those new protocols to see if there's any kind of additional updating or refining that needs to be done moving forward when we audit that. When will the 2016 protocols be released? I'm hoping that I get some, whoops, hollers, or just smiles at the very least when I say this. So since we have made a lot of updates to the 2015 protocols and are going to repost them, hopefully in September, those will be the 2016 protocols. We are not making any additional changes. Thank you. So you will have them probably in September. We are hoping to really kind of keep things steady and even for a couple years, allow the industry to get caught up, allow us to get caught up. So we'll have those out and they won't change moving forward. I wanted to talk a little bit about the inaccurate universes that are submitted to, as I mentioned previously. So you'll see that we have indicated in the protocols that will be reposted that moving forward for 2016, we've created a new condition type. It's called invalid data submission, or IDS. So in addition to a CAR, an ICAR, an observation, there'll now be an IDS type of condition. So when you are unable to submit accurate universes within 3 tries, there will be a certain set of IDS conditions around any element we can't test. So for example, if the inaccurate data is just in CDAG, let's say, and it's just around dates and times, so we can't do your universe timeliness test for one or 2 or 3 of your universes, you will get a specific IDS condition relative to our inability to test decision-making notification of standard coverage determinations. They'll be worth 1 point, not 2 like an ICAR. And obviously, as ICARs require that 72-hour correction, the IDS conditions will not. We will validate correction during our validation exercises. And one of the other things that I just wanted to mention is we did clarify for 2016 moving forward in ODAG and CDAG, grievances will be based on, I want to make sure I say this right, the universes will be pulled based on the date of the resolution of the grievance, not your receipt of the request. So that's pretty much it for 2016. So nothing else is changing at all. So just quickly, tips to prepare. I've talked about this before, but I thought it would be helpful just if we're talking about preparing for 2016, we could go through it really, really quickly. So read through all the protocols. I know most of you do because I see the volume of questions in the audit mailbox. Thank you very much. So we really appreciate all your questions and your feedback, and it helps us think about things differently. So go to the website, download the protocols, read through them, read through the data dictionary, see if you have any questions, email that audit mailbox if you do. Make sure that you have and can pool, your systems are programmed to be able to pool all of the needed data. And this includes, I have it on a lower bullet, but it includes your FDRs. So for example, if you are a larger organization that has subcontracted entities performing your organization determinations or your grievances, when I say to you, I want all of your organization determinations and grievances, that doesn't just mean what you processed in-house. It means what you processed, what your downstream entities processed. If they did ODs and grievances for you, I expect that all to come to me in one data universe. So not only do you need to be able to produce it, you need to be able to compile it from any of the outside entities who are performing these services for you. And you don't want to do that the first time after you've gotten a start notice, because you've pretty much put yourself behind the 8 ball, I think, at that point. Identify your internal team. Know who is going to lead CMS through that audit. Have them pull up screens, practice with webinar technology, practice going through the audit, practice handing off screens. Like if you are going to have an FDR who's going to present some cases and someone in-house who's going to present others, have them practice sharing the screen back and forth, or changing hosting responsibilities, so that when it comes time to do the audit, your internal team is very familiar with what they need to do, and they'll be less nervous about doing this. And obviously practice, practice, practice once you've done all that. If you receive a start notice, please be sure to ask questions if you have them. There will be a call scheduled 2 days after you get that start notice. It'll indicate who your auditor in charge is. Make sure you reach out to them. Don't be shy. We'd rather you ask the question and get it answered than get it wrong. And also, when you have that call with CMS 2 days after you get your start notice, please be sure to have the right people in the room. I probably sound like a broken record, I've said this before, but we love and appreciate that your CEO is there and maybe a member of your board, but I don't think they're the people programming your systems and pooling your universes. And so it's nice to have them there, but make sure the person who's pulling that data, who may have more operational questions, is there and can get those questions answered by CMS on time. And last one's just kind of a given. I know audits can be nerve-wracking, but we really are here to help. Our goal is not to play gotcha. Our goal is to help you improve your performance. This is a learning, hopefully going to be a positive learning experience for your organization. So try to breathe and approach it as such. Yep. There we go. Okay, so you've received your audit engagement letter. Now what do? I wanted to run people through some just kind of deliverable dates. If you haven't been through an audit, you may or may not be completely aware of what these are. So you've got the audit engagement letter. I mentioned the follow-up call 2 days after where they will talk about universes and the general process, probably introduce you to the team. Within 5 days, you're going to submit your list of self-identified and self-disclosed issues to CMS. I want to reiterate here, since it's a question we've gotten many times, you may limit that self-identified and self-disclosed list to items that are within the scope of the audit. We're not asking you for every issue you identified across your operation, just what you think is pertinent to the audit itself. Submit all universe data within 15 days. Please quality check it first. A lot of times we've gotten questions about what database we use to validate our data and how we're checking it. I don't think we don't have a database that I'm aware of that we're using to validate our data. It's really like opening up, looking for missing fields, looking for time fields and date fields, looking for vice versa, looking for things that are NA where it should be, a name. It's stuff that anyone could see with the human eye. So really just take a minute to sit down and review the data before you submit it. I think we'd rather give you even a day or two extension on submitting something than have you rush and submit something wrong. So we will then, for ODAG and CDAG, once we validate it or looked at the data, we'll take probably 2 days to analyze the data, and then we'll schedule what we call universe validation webinars. That's simply to make sure that the dates and times that are in the universes you submitted are the dates and times in your system. If everything is copacetic, we will run our universe timeliness test so that we can provide that to you when we get on site. And then the audit will begin 6 weeks after receipt of the audit engagement letter, starting with your entrance conference. So week 1 of the audit is generally via webinar. This is when CDAG, ODAG, formulary, SNP mock, and potentially 1 to 2 of your CPE tracer samples will be done in that first week. We will continue to ask for beneficiary impact analysis for issues found on audit. We have also slightly changed this process. We will no longer be asking you to go back to the first of the year. We will just be asking you for the 3-month time period that preceded the date on your audit start notice, up to and including the date it was found during the audit. Week 2 is your CPE review, so any tracers that were not done in week 1 will be completed during week 2, and that's generally done on site along with all of the staff interviews and compliance officer interviews. We will then hold an exit conference. The goal is to get you a draft report 60 days after the exit conference, and then you have 10 days to respond to audit findings that you don't agree with and provide any documentation that you would use to support that disagreement. And then we would send you a final report. You have 90 days, and then I believe we schedule your validation unless you come to us and openly tell us you're not ready, in which case we're not going to come out if you tell us you're not ready for us to validate. And once we've completed validation and we've assured that you've corrected all of the issues we identified on audit, we would then actually officially close out the audit, and we say you're released from audit. So at that point, you're done and you can go on your merry way, and we've hopefully corrected many, if not all, problems. So with that, I'm not sure if we have time for questions, but.
Actually, we have time for one question. And we will address any other questions during the open Q&A session at the end. And I see that we have an in-house guest with a question, so please go ahead.
Here's my one question, which will be quick, so hopefully there'll be time for another. With regard to open or forthcoming 2015 audits, is the change regarding the beneficiary impact analysis for self-disclosed issues in effect, or is that just going forward for the 2016 audit cycle?
Okay, so if I had a little bit of trouble hearing you. So you were asking about the change for BIAs with respect to
the self-disclosed and self-identified issue for open audits or for audits that are forthcoming in the 2015 audit cycle.
It'll be forthcoming audits. Obviously, if we're already in progress, you've probably already had the BIA requested of you. But moving forward, we will no longer be asking for that to be submitted.
Thank you.
Okay, and that is all that we have time for right now. And so I would like to thank you to all of our speakers who provided information to get us prepared for 2016. Here with us today to discuss the potential effects of socioeconomic factors on star ratings from CMS, Elizabeth Goldstein, and from the Pardee Rand Graduate School, Cheryl Denning.
So both Cheryl Danberg and I will be doing this presentation today. So I'm going to start off by giving you a little bit of background. Okay, sorry. It's over there. Hold on a sec. Thank you. So today we're going to be talking about an issue that I know a lot of you are interested in. Multiple organizations have suggested that contracts that enroll a high percentage of dual or LIS beneficiaries are disadvantaged in our star rating system, and that they cannot achieve high ratings. So this is the issue that we're going to be talking about this afternoon. The goal of the work that we've done is really to provide evidence, the scientific evidence, about whether MA or Part D sponsors that enroll a large percentage of vulnerable beneficiaries are really disadvantaged in our star rating system. Most of you will remember last fall we did a request for information, and we conducted some initial research that we put out last February. As you recall, the findings from the request for information was mixed. And our research also suggested we needed to really better understand what factors are driving differences in performance when we saw differences. I just want to note, today we're going to be talking about the star ratings, but there are parallel analyses being conducted to determine if there need to be any changes related to payment risk adjustment models. For the star ratings, we're very happy to see that sponsors really have responded to the star ratings and have conducted many different quality improvement initiatives that are reflected in their scores. I just want to note, and most of you are familiar with this, each year we continually review the star ratings, the measures that are included, as well as the methodology to make improvements and refinements in the system. And we want to ensure that we're truly measuring quality and the experiences of the enrollees. So for example, this year we made some changes to the calculations, and that's really the goal of that was to make sure we're accurately measuring performance. So our policy goals. We've been really working to build a foundation for a solution that addresses the issue at hand. So there are a number of things that we've been thinking about and goals as we're thinking about this issue that I want to go over before we get into the research findings. We do want to recognize the challenges of serving vulnerable beneficiaries, and we want to make sure we're creating incentives for health and drug plans to improve the care that they're providing. We want to propose any adjustments going forward that reflect the actual magnitude of the differences we're seeing in the data. So that's really critical. We want to provide valid ratings to facilitate consumer choice. So we don't want to, if there are disparities of care, they're due to differences in quality, we don't want to mask these differences. We want to continue to provide incentives for quality improvement. We recognize that any options that we consider have to be transparent for everyone. Plans need to understand what we're doing, how we're doing the calculations, so that's very important to us. I want to also, in terms of any adjustments going forward, generally through adjustments, some plans are going to benefit from the adjustment, and in some cases, others may experience lower measure scores. So I just want to note that, because sometimes we get the question, if we do anything for the differences we're seeing, will the scores of all plans go up? Probably not, because the nature of adjustment is, some scores are probably too high and some may be too low. So we've been doing, during the past year, a lot of research with the RAND Corporation, and Cheryl Damberg is the project director of this work, and she's going to be continuing with the presentation.
Great. Thanks, Liz, for that setup. What I'd like to do now is transition into the work that we've been doing to try to understand what is going on related to potential disparities in care and the implications in the context of the star ratings. So just as background, there has been previous work that has been done by the Medicare Payment Advisory Commission, MedPAC, which I think most of you are quite familiar with that organization. And their work suggests that disability could be a driving factor in some of the differences that have been observed in performance in the star ratings, rather than some of the variables that people frequently mention, such as low income status. If you look at the distribution of the overall star ratings by the percentage of LIS and dual eligible enrollees, that information actually shows that some of the contracts that have a high percentage of LIS and dual eligible enrollees can actually achieve high star ratings. So, clearly one of the challenges out on the street is that you don't necessarily want to be adjusting away where people have been able to close that quality gap. I mean, that's our goal here, is to close that quality gap. So one of the things that CMS has been exploring, and RAND has been supporting them in this effort, is to examine what some of these potential effects are related to low-income subsidy, dual eligibility, as well as the effects of disability on the star ratings. And the slides I'm going to show you focus primarily on what's happening in Medicare Advantage, but these analyses have been going on in parallel for the prescription drug plans as well. So again, just to note, the National Quality Forum came out with a report last year and really flagged or highlighted the importance of trying to understand the effects of socioeconomic and sociodemographic differences across providers and the effect that those might have on the performance measures, particularly in the context of accountability and payment applications such as pay for performance. I should note or flag, and I think most of you are probably aware of this, that in the context of the Medicare Advantage star rating program, two sets of measures are already adjusted. One being the CAHPS patient experience survey, and then some of the measures in the health outcomes survey. And these are adjusted for the characteristics of patients, including education, LIS, dual eligibility, and health status. So let's take a look here, and this pie chart is designed to show you in terms of the percentage of all Medicare beneficiaries, how they split out based on whether they are not dual eligible or LIS, and that represents about 74% of the beneficiaries. And then among that 26%, that are. You have about 9% that are disabled only, 11.3% that are LIS or dual only, and then you have 5.8% being both. And now this next slide just looks at that slice that are either dual or LIS, so that subset of the 26%. And so if we look at that share, what you see is most of the beneficiaries are either disabled or LIS dual, and 22% are both. So it gives you some sense for what this population looks like. So now if we look at how these people distribute themselves within contracts. So again, here we're focused on Medicare Advantage contracts and looking at the percentage of LIS dual eligible beneficiaries within these contracts. And what you see on this graphic is what statisticians refer to as a bimodal distribution. So to the left of this figure, you see that there's a large number of contracts that have a very small percentage of LIS or dual eligible beneficiaries enrolled in their contracts, less than 20%. And then off to the far right side, you can see that there's another subset of contracts that have a very high proportion of dual eligibility LIS, up to 100%. Obviously, the dual SNPs count in this space. And so a fairly large range of penetration of these dual eligible LIS beneficiaries across contracts. Now, if we look at this same figure for disability, you see a slightly different picture with most people being, or most contracts being off to the left-hand side of this graphic, where most contracts have less than 25% of their enrollees classified as disabled. And a very small fraction of contracts have a high percentage of disabled beneficiaries. So one of the key questions that has been raised out there is, can contracts that have a very high proportion of LIS or dual beneficiaries achieve high star ratings? And I think that this slide helps illustrate that in fact they have and can. But let me explain to you what's going on here. So, oops, sorry about that. If you look at the x-axis or the horizontal axis, what we've done is we've categorized contracts by the percent of LIS enrollees in the contracts. So to the far left, you have contracts that have 25% or less LIS enrollees. In the middle, you have 25 to 75% of the enrollees are LIS dual, and off to the right, greater than 75%. And what you see is in all three categories, you have contracts who are able to get 4 stars or higher. Most are getting 3 to 3.5, and then the blue is the below 3 stars. And clearly the contracts all the way to the right that have a higher proportion of duals or LIS beneficiaries, a smaller fraction of those are able to earn or have demonstrated that they are able to earn 4 stars or higher. But clearly there are contracts in that space that are doing so. So as we went about the analysis, because I think probably most of you can appreciate that this is challenging work to really parse what's going on, it's important to think about there's the total disparity, but then breaking that apart into basically 2 components. And I'm going to refer to those 2 components as the between contract disparities. And these differences are the differences we don't want to be adjusting away because they represent true quality differences between contracts. Then there are the within contract differences or disparities between different subgroups. So let's say beneficiaries who are LIS versus non-LIS within the same contract. And these are the types of disparities that may be appropriate for adjustment because they may signal either some kind of mismeasurement problem or some type of unique challenge that is outside the control of the provider. So many of the previous studies have lumped together those two component parts and said that this is the total difference that should be taken into account. However, as I've noted, we don't want to be adjusting away true differences in quality between contracts because that's ultimately what you want a performance measure to do, is measure true differences in quality performance. So the between contract disparities really are getting at, whether low SES beneficiaries who often are enrolled in these lower performing contracts may be served by lower performing providers. Whereas in contrast, the within contract disparity looks at low SES beneficiaries who actually may receive worse care within the same contract. And so there are other factors at play that are contributing to that. Now, I should note, as is shown on this footnote, you can have contracts that have no difference or disparity between, say, LIS and non-LIS beneficiaries. Now, that may be because that contract has managed to successfully close that quality gap and has high performance. But it also could mean that they don't have a disparity, but everyone in that contract is getting low quality. So just keep that one in mind. So one of the approaches to addressing this is what people refer to as case mix adjustment. And the idea behind case mix adjustment is you're trying to level the playing field, to make the comparisons fair across contracts. And the adjustment works such that the contract is basically serving the same mix of beneficiaries when you make that comparison. And the idea here, and going back to the slide that Liz showed that talked about the goals, the main thing that you don't want any measurement program to do is to create incentives for providers to not want to care for more challenging patient populations. So by working with case mix adjustment, you can reduce the incentives for that to happen. So I should sort of pause here and note that while case mix adjustment may be one potential strategy, CMS has as a priority to use consensus-based measures. And so there are a variety of measure developers, such as the HEDIS measures that have been developed by the National Committee for Quality Assurance, the Pharmacy Quality Alliance measures, and measures endorsed by the National Quality Forum. Now, those measure specifications can only be changed by the measure steward, because they are the owner and the developer of the measure. And so that process is often multi-year. And so while the measures are currently being reviewed for the possibility of case mix adjustment, CMS is going to be considering other possible interim solutions. But I should note that the National Quality Forum is trying to go back to measure developers and have them revisit a whole host of measures, not just those that are in the Medicare Advantage star rating program. So let me get into the thick of the analyses that we did. So we selected for study measures from the Medicare Advantage star rating program. So I noted earlier that the CAHPS measures had already been adjusted and a number of the HOS measures, so those we did not consider. We also did not focus on measures that were not a beneficiary level issue, such as the call center or appeals type measures. And we also excluded from our review measures that were either going to be retired or revised. And we also excluded measures that were applicable to only special needs plans. So our analysis looks at 16 clinical measures, and I'll show those to you in the next slide. So you can see on the left-hand side, we have the HEDIS measures. On the right-hand side, we have 2 HOS HEDIS measures and then 3 Pharmacy Quality Alliance measures. So these were the measures that we explored, and in the next few slides, these are the measures I'm going to be speaking to. So when we did the analysis, and what I'm going to show you over the course of the next few slides, is we broke down our analysis into steps so that we could basically understand the problem, and it's basically a building block approach, if I could say, what's happening here. So the first thing we did was to look at the association between performance. So this is at the individual measure level, looking across all Medicare beneficiaries. So this is not a contract level analysis. This is looking across all beneficiaries and looking to see whether there was a lower likelihood that LIS, dual eligible beneficiaries or disabled patients were likely to receive that recommended care process or achieve that particular clinical outcome as measured by those measures. So and the way that the information is going to be reported on the next few slides, we are using something called an odds ratio. And that odds ratio is looking at the likelihood that you receive this particular clinical process measure if you're low income, dual eligible, or disabled. And I should note that on the next few slides, the results I show are going to show that they are statistically significant, but please note that you need to be careful in interpreting this because we have very large sample sizes. So even very small differences can show up as statistically significantly different. What's important here is to consider the size of the effect. So is the magnitude of the effect meaningful? So on this first slide of results, so again, this is all at the beneficiary level, not a contract level analysis. So you see down the left-hand side of this slide the HEDIS measures. And in the 2 columns, this is based on a regression model that included a contract fixed effect, which is basically controlling for that between contract variation. And then the other variable in the model is either the person was LIS dual or they were disabled if you're looking at the far rightmost column. And so again, just to help you with the interpretation of what's on this slide. So in this first row for the adult BMI assessment measure, what this is showing is if the odds ratio is greater than 1, that's basically a positive disparity in favor of the LIS dual eligible beneficiary. So in this case, if you're a dual eligible LIS beneficiary, you have an 11% higher probability of getting a BMI assessment than being non-dual or non-LIS. If you look down to the breast cancer screening, this is a value that's less than 1. So anything that's less than 1 on this chart and is labeled in orange, this is showing a negative disparity for the LIS dual or the disabled population. And so for breast cancer screening, that value is 0.69. And what that means is they have a 30% lower likelihood of getting breast cancer screening if they're LIS or dual. So hopefully that was clear in terms of the explanation. And so now I'm going to go on to the Hassan PDE measures. And again, what you can see here is that out of these 5 measures, 3 of them are showing negative disparities for LIS dual, and the reducing risk of falling shows a positive disparity. So LIS dual and disabled beneficiaries are more likely to have this done to them. And then the value that's in black with no stars behind it, that shows a non-significant result. So there's no difference between the LAS dual and the non-LAS dual. So to summarize what you've just looked at across these slides, what we find here with these measures is that most of the associations between being LAS and the likelihood of getting that recommended care process or achieving that outcome were negative. So this means that vulnerable beneficiaries were less likely than the non-vulnerable beneficiaries to receive that recommended care or outcome. For a small subset of the measures, the association was positive. So for these measures, the vulnerable population is more likely to receive that recommended care or achieve that outcome. And if we compare the disability model to the LAS dual eligibility model that adjusted, we saw slightly more measures that demonstrated a positive association with disability as compared to the LAS dual. And then, as I noted, there are a handful of measures where we see no significant difference between the LAS dual and the non-LAS dual. So this chart tabulates, and what you can see is that there were 12 measures for LAS dual and 11 for disability that showed a negative effect. There were 2 that had a positive effect, and 3 for disability, and no effect for 2 with LAS dual and 1 for disability. So there has also been suggested that one should look at other characteristics of beneficiaries for possible adjustment. And when we did analyses that explored the effects of other possible socioeconomic, sociodemographic adjusters, I would say the net result was we did not find much difference in terms of the effect on LAS dual and disability. When we added these other adjusters to the model, they really did not contribute much. And so in the subsequent slides that I'm going to show today, we did not include these characteristics, but I wanted to highlight for you that we included things in the model in addition to LAS and dual or disability that included age, gender, the HCC score of the patient, whether they had end-stage renal disease, and we also, using census data, matched to the patient's block level information about education and income and poverty. So, as I noted, these other variables did not really add much to explaining the variation. So now we're going to shift gears and look at within contract variation in these disparities, because what we have noticed is different contracts have different disparities between their LIS and non-LIS population. So the question is there a disparity and how big is it, and how does that vary across contracts? And so what we did here is we figured out the proportion of beneficiaries who received the measured clinical process or outcome for the LIS and the non-LIS beneficiaries. So that was estimated separately. And then we computed the difference between those. And that is what is going to show up on this next graphic. And so hopefully this is not going to be too confusing when I explain it. So what you see here is, if you think of that bar that's going across the graphic, that represents all of the contracts for a particular measure. So let's take breast cancer screening, which is at the top. And the blue bars represent the minimum and maximum within contract disparity. So on this measure, you can see there is some contract that's sitting out there with a maximum disparity of negative 22.2 difference between their LAS and non-LAS population. And then you've got a contract all the way to the right, which is, I'm eyeballing this, about 5 percentage points in the positive. So their LAS population is doing better than their non-LAS population by about 5 percentage points on that measure. The red dot in the middle of this bar represents the middle 50% of contracts. So that's the median. And then the white bar represents 90% of the contracts. So you can see, if you look down all of these measures, that for a number of the measures, they're in that gray space, which means that, so 0 means no disparity if you're looking at that x-axis. The gray area is a negative disparity. That means lower care or lower likelihood of receiving care on that particular measure for an LIS or a dual eligible beneficiary. What you see is that for a number of the measures, they're in that gray space, showing a negative disparity, which is consistent with the earlier results that I showed. However, these within-contract differences between their LAS and non-LAS populations tend to be relatively small, all things considered. And for many contracts, they're actually in the positive zone. Similarly, if we look at disability as the measure of disparity, we see a somewhat different pattern, more bouncing around, so it has a different effect on some of the measures. We have several measures that are much more in the positive zone for all contracts, and then we have a handful of measures for which contracts are more negative. So it really matters which of the disparity characteristics you're looking at. But to summarize what we were looking at in these graphics, so we do see evidence of differences in performance between LAS and non-LAS and the disabled and non-disabled within contracts. So you saw a fairly broad range across contracts on most of those measures. The median within contract disparity, if you remember the red dots going down the graphic, indicates a fairly small LAS or disability effect. And as I noted a moment ago, for some measures, the LAS dual or disabled group actually outperforms their counterpart. So if we're focusing strictly on an LAS dual eligibility effect, I think you can see, if you remember from the slide I showed a moment ago, the results are fairly mixed. The majority of the measures that we examined had a small negative within contract difference or no difference. And what this means is that for some measures, that negative within contract difference, the LAS dual eligible beneficiaries have worse outcomes as compared to non-LAS. But for other measures, the LAS dual have similar outcomes or in some cases better. And if we're now thinking about the disability effect, the results were a bit more mixed. The majority of measures examined had a negative within contract difference. Some had no difference or a positive within contract difference. So to summarize, this table shows you the median percentage point difference between the different groups. So for those contracts that had a within contract difference of -2 or lower, so more negative, there were 8 measures when you adjusted for LAS, and there were 10 when you adjust for disability. The greater than 2 would put you in the positive space, the white area of those graphics, where the LAS are doing better than their non-LAS counterparts within contract. And we saw 1 measure when we adjusted for LAS dual, and 3 out of the 16, or actually 15 in this case, for the disabled versus non-disabled that are doing better. So you can see it's rather a mixed story here, and it really depends measure to measure what the effects are. So to summarize, the research to date has provided scientific evidence that there does in fact exist an LIS dual or disability effect for a small subset of the star rating measures. And I do want to underscore that the size of the effect is small in most cases, and it isn't always consistently negative. So I think I have a couple more minutes, and I can show you a few more results from some models we ran. So we were also asked to look at models where we included both LIS and dual eligibility as well as disability in the model, and to see how that might have changed our conclusions. And I think what's interesting to note is that when we put both of those socioeconomic, sociodemographic factors into the model, in many cases, the effect is more modest. So for example, if you look at breast cancer screening, if we adjust only for LIS dual eligibility, recall I said that the likelihood of getting breast cancer screening is about 30% lower for an LIS dual eligible patient. Once we control for LIS and disability, now that number is 0.75, so it shows that it's about 25% lower likelihood. So it sort of moderates that effect somewhat. In some cases, such as diabetes care eye exam or the kidney disease monitoring, while the effect was slightly negative when only adjusting for LIS dual, once we account for disability, the effect goes slightly positive, but it's no longer significant in terms of there being a difference between those people who are not disabled or not LIS and those people who have both of those characteristics. So that gives you a sense when we're controlling for disability. Similarly, we see that on the HOS and the PDE measures, that it tends to moderate the effect for most of these measures, particularly the three at the bottom. So now what we're looking at is when we compare to just controlling for disabled, and we include both disability and LIS in the model, again, we're seeing some moderation of the effect. So those associations become, in fact, smaller. So if we look at breast cancer screening again, you can see that the effect was 0.72, and now it shifts slightly upward, back in the direction of 0 to 0.75. So the likelihood of not receiving breast cancer screening is smaller than it was when only adjusting for disability. So you can see that we've done a lot of work to explore the effect on individual measures, really understand what's going on in this space, to help CMS consider how they might proceed in the future with trying to come up with solutions that will help improve measurement that will feed into that star rating program. So I think with that, I will close, and I think we're ready for questions.
Hello, are you ready for questions? Do you want any questions?
No questions allowed. No, actually, we have time for questions, so go ahead with your question.
Okay, so it's a quick question. Basically, it seems like the evidence on a measure-by-measure basis is mixed, right? And what it seems to reflect in a lot of cases is it's almost like a service thing. It's almost like people aren't getting the services if they're in a particular category. So the fundamental question is sort of one of causality. It's why? You know, I mean, I know some of the measures are positive, some of them are negative, and none of this really explains why you would find differences between the groups. And secondly, I mean, when it comes right down to it, performance measures are all about, are the people who get the treat or who need the treatment getting the treatment? And if they're not getting the treatment, kind of regardless of why at some level, well, maybe not regardless of why, but if they're not getting the treatment, then the rating measure should reflect that and should be lower. So it's partly a question, partly a comment. And I think the question goes to I can't see any causality here. And secondly, if the measures reflect what they reflect, then the scores will reflect that too. So, hope that makes sense.
Thank you for that comment. I think you're highlighting sort of the complexity of trying to really understand what's going on in this space, and what I think the research community and providers who deliver care to patients really have been struggling with understanding is what are all the different factors that are driving the reasons why people aren't getting care. And I think fundamentally, when we think about case mix adjustment, I'll take you back many years to, hopefully I'm not going to embarrass CMS when I say this. So there was a period of time when they measured hospital performance, mortality rates, and they did not adjust for differences in the sickness level of the patients that the hospitals treated. And that is the classic example of mismeasurement, right? Because you really haven't accounted for all the factors that contribute to that outcome. And this is why people feel very strongly about case mix adjusting outcomes. When it comes to clinical process measures, that landscape has been a little bit more challenging to try to understand. And so when I was explaining the issue of between versus within variation, the idea there is you don't want to give what I'm going to call a hall pass to low-performing plans or contracts or providers. It doesn't matter what measurement program we're talking about, whether this is Medicare Advantage star rating or some other, quality measurement program. So you want to be able to preserve the ability to look at those differences because you want to create incentives for providers and the plans that contract with those providers to improve on those measures for all patients. What you really want to try to understand is, are there certain things about some beneficiaries that make it much more challenging for the provider to succeed in being able to deliver appropriate care for those individuals. And maybe that's a literacy issue or a language competency. So that's really what that within contract variation is trying to tease out and potentially give contracts an opportunity to be put on a level playing field about dealing with those patients.
Okay, we have another question from our in-house audience. Go ahead, please.
Yes, thank you. And this question is also for Rand. I'm wondering if you can help me understand some of the sort of summary statements and conclusions you drew on that summary slide. In particular, you concluded that the effects were small. The effect of let's say the disability or the dual LIS impact were small, but I think that was in relation to particular measures. I didn't see where you sort of aggregated the impact to look at the impact on star ratings overall. Do you have any assessment of how the results that you showed, whether that effect on actual star ratings is small?
So from this slide that we just pulled up, you can see there the impact is small for most measures that we examined here. A lot of the other measures included in star ratings are either adjusted or really aren't measures that would be impacted by these beneficiary characteristics. So overall in the program, the number of measures impacted is small. CMS is currently doing work with ASPE as part of the Impact Act, looking at the impact overall, as well as looking at whether we should be making any changes to the star ratings program. So one of the things that CMS has done has asked measure developers, such as NCQA and the Pharmacy Quality Alliance, to look at these measures and see if they need to build in any case mix adjustment models into these measures. That work always takes multiple years as part of the consensus-based process. So CMS and ASPE are looking at what is the impact overall of these differences, and given it'll take measure developers a while, seeing do we have any interim solution. So in our request for comments this fall, we'll provide some information about this very issue and any proposals that we have for moving forward. It may be moving forward in the interim.
Yeah, and I also want to just flag for people, I know that sometimes contracts do their own analyses, and I would definitely kind of point you back to the slide that referenced a lot of previous analyses look at the total difference. So it includes both that between and within. And in essence, if you consider that total difference and sort of trying to think about a fix for that, you would be doing what I would call overcorrecting and basically wiping out true quality differences. So that's a point I want to make sure people leave here and understand that distinction.
I think I was just going to add, related to that, when we did our request for information last fall, we were initially very puzzled where one submission would say there are no differences, the next one would say differences are in this direction, the next one we would read would be differences in the opposite direction. And I think this figure here helps you see that there is a lot of variation for most measures across contracts in these within contract differences. So I think that's an important point. So at first we were very puzzled, why is one submission saying one thing and the other saying something else? But they're truly, for not every measure, but for most measures, there is a lot of variation across contracts. So I think that's important also.
Okay, we do have another in-house question. Please go ahead.
Hi, thank you. I want to thank CMS and RAND for doing this study. It's so important for all the reasons that you said. I think these findings are phenomenally interesting and important. I want to echo what the former person said. I think that was Lynn Nonamaker, on taking issue with the idea of these findings being small. I see that statistically these are potentially small or related to the total disparity. You're trying to sort of isolate the within contract, so then it's small relative to the total. But if these findings were taken into account, and if these findings are accurate, which I think that they are, this is a very robust analysis, then for plans that are on the cusp of some of the thresholds in the star rating system, and there are many thresholds at the measure level, at the star rating level, these smaller differences matter a lot. So small but significant is sort of what I'd want to say, in that we really encourage CMS to make these adjustments, and because they can matter a lot. These the star rating system is filled with thresholds. So these smaller differences can really matter significantly, and a lot of plans that are serving these populations are disadvantaged by the financial impact of not making these adjustments. So we really appreciate CMS's, persistence. We know you've gotten so many, so much feedback, and this is just these findings I think are just phenomenally important, and we would want you to go forward. And even though small, we think that they will make a difference in the end because of the way the star rating system is so complex. So we really do encourage you to go forward in the long run, with case mix adjustment, but in the short term as well. Thank you.
Thank you for those comments. It's something CMS and ASPE are looking at right now. So I guess the only thing I would say is stay tuned for our request for comments this fall. It's definitely an issue we're exploring, looking at the total impact and looking at any possible interim solutions.
Okay, we do have another in-house question. Please go ahead.
Hi, thank you. Is CMS planning to make any more of the data or the methodology public?
So we're going through right now all of our findings, and so if as we go through it or people have questions on particular pieces of this, we may release additional slide decks summarizing the findings. We're also doing, as I said before, additional analyses looking at the overall impact, and those will be forthcoming.
Okay, we do have a little bit of time left, so I would like to address some of the questions that were received from our webcast audience. And the first question received is as follows. Terminations for low-performing plans will be issued early next year based on star rating scores. Does CMS still plan to issue these notices, given that they do acknowledge that there is a SES impact on the ratings?
That's a good question. We do not plan to change our decisions regarding terminating low-performing contracts. I think through this research, we do see that there are not differences that would prevent a contract from achieving 3 stars. Furthermore, there's nothing in these findings that would suggest that a contract over 3 consecutive years could not achieve 3 stars. So we are not, changing our decision regarding the LPI contracts.
All right, our next question received via our viewing audience. How is this research different from the prior CMS research?
So the research we did last fall really focused on the LIS and dual eligibles. Through that research, we felt like there were other factors potentially driving the observed differences. At the time we were doing that research, MedPAC was also doing some research seeing a disability effect. So we thought it was important to really understand all of these factors. So this research really took the next step at looking at disability, as well as looking at other characteristics to see if they were, drivers of these differences, such as age, risk scores, ESRD status, census block characteristics. So we have, looked at that also.
Okay, and one last question that was received from our viewing audience. The ASPE study focusing on SES and star ratings is not expected until 2018. Does this presentation represent your short-term position? Is CMS still open to considering additional modifications dependent upon what the ASPE study finds?
So, as I said before, CMS is working very closely with ASPE. So we've also asked, as I said before, measure developers to look at the specifications for the consensus-based measures to see whether they do or do not need case mix adjustment. So we're working really hard to come up with some interim solutions that really match our policy goals. So we want to make sure the solutions, match our findings. When we see, for example, sometimes duals do worse, sometimes better, it really needs to, the solution match what we're seeing in the data, also the size of the effect that we're seeing. So stay tuned for our request for comments. We're working very hard right now to come up with some interim solutions that we'll put out for your input in our request for comments.
Okay, that is all that we have time for right now. So I would like to thank both Liz and Cheryl for their time today. All right, our last session today is something that we have done a couple times now. So it's sort of new, but we're still playing with it and finding that it's one of the more popular sessions. So basically, it is an open Q&A session, and what this means is that our speakers from today are going to all join us here on the stage, and we are going to go through the agenda session by session and address any questions that we were unable to get to earlier in the day. We will have approximately 2 to 3 minutes per session to ask questions, and some of that may differ by session depending on how many questions we received. So, with that said, if we do not get to questions that you had sent in because we received so many, we will certainly make sure we address them, answer them, and then they will be posted on the CTEO website. So if your question does not get answered today, please look there at a later time and date. Okay, if I could please have the first group come up, and that would be the group that presented the Beneficiary and Pharmacy Outreach Lessons Learned in Part D, please. All right, the first question that was received. Ms. Swanson and Mr. Wells mentioned having, I think I did that one already. Yes, sorry. Okay, going down. What do you see as the most challenging piece of informing and educating members of the network change so far? What proactive actions is Etna planning to take to prevent any similar member confusion as it encountered in 2015?
So, the most challenging aspect of this was making sure that our beneficiaries understood what pharmacies they could go to for prescription drugs in 2015. And again, that's our focus in 2016. What we really try to do in these personalized letters is not only explain to them the medication they're having, but also what pharmacies are available to them within a limited geographical area for them to receive those medications.
Okay. Our next question that was received from our audience. The presentation slides indicated that the former Coventry members will remain in the expanded network throughout 2015. Is Etna reaching out to those members who, we did this one too. So sorry. It's a great question. Maybe we should do it again. All right, we'll move on. What is your process for handling repeat complaints from members about a particular pharmacy? At what point do you remove them from your network?
Interesting question, because our approach to pharmacy contracting was to expand our network through this process. If we had repeat complaints about a specific pharmacy, we would actually go and meet with that pharmacy. There were some cases where we actually did that on an in-person basis if it was needed. So.
Okay, thank you. Next question. During the time that you had to open up your network, how did you address standard versus preferred cost sharing for members?
When we opened up the network to our broadest network, that was on our standard network only. It was not on our preferred network.
Based on your interventions, was there a change to your Part D CAHPS star rates, CAHPS?
We've noticed a change in our CAHPS rating, and we're working to address that. The information has recently come out, so we're analyzing it. There was some negative impact from members as a result of this situation.
All right, and I have one last question here, and that question is, would it be advantageous to advertise upcoming change via radio or local TV? Give a toll-free number to call for questions and concerns.
You know, we looked at that again. Our approach was that generalized letters were not as effective with our members as more targeted letters that discuss their specific situations. So we have not used general radio or TV advertising for that. In all of our communications, we continue to provide members with our toll-free number to contact us.
I just wanted to add that all plans are required to have a 1-800 toll-free number, whatever version of toll-free you would like to have for both pharmacies and members' services.
Okay, well, I'd like to thank both Linda and John, and I'm going to ask our next group to come up, and that is, thank you. That is going to be the Alternative Payment Models panel. Our second session, which was the update on CMMI demo, that speaker was unable to be with us today, so if you did send in a question for him, we will make sure that he gets it and it gets addressed. I'm not sure everybody is this tall. Oh, there we go. All right, sorry about that. Okay, moving on to the Alternative Payment Models panel. We do have a couple questions that were received, and also remember our in-house audience, if you do have a question, please step to the mic in the center of the room. The first question that we received, what are the keys to successful collaboration with providers?
Well, I think from the conversation that we had together as we went through our presentations, it really was taking the time to align with the provider's unique skills and competencies and not try to force, from our perspective, a one-size-fits-all on what you're trying to do, and also being cognizant of rural versus metro, specifically in our case.
I would add that there are a couple of things that we look at to have a successful collaboration as well. The first one is aligned incentives with the providers. And what that means is that the incentives that you're paying, for example, for an IPA, are then translated for the outcomes to the frontline PCP and specialty providers, not just staying in the administration of the group. So I would say that's an important aspect, aligning incentives. Clinical engagement is another key factor of success. Having medical physician directors and medical directors that are aligned and are really engaged in the process of talking through the care management plans and the transformational care plan that you put together and working together. So I think there are a couple of other main factors, but if you can get those two things aligned, your organizations will have a better success or chance of success for a collaborative arrangement.
Okay, we have time for one more question. How does the use of alternative payment models translate into timely and efficient care for beneficiaries?
The structure of the aligned incentive payment needs to look at the quality of care, the cost of the care, and the customer satisfaction. I think Julie was referencing there needs to be champions within the provider practices to lead this. It can't be just a contract through the contracting arm. And when you can bring the data closer so you can see real-time information shared with the systems, it really is very powerful if it's structured appropriately and sharing throughout the care system that you're working with.
I would just say that's exactly right. I think getting the data timely and communicating, having a large sense of transparency with your providers does then result in care that is more timely and ideally preventative and proactive, to avoid any kind of acute situations.
Okay, thank you so much. All right, I'm going to skip over our next session, which is Part C&D Appeals, and only because I don't have questions in front of me for you, so I think I'll come back to you toward the end. But I would like to invite up on the stage those who participated in marketing policy updates, and that includes Carrie Casey, Jeremy Willard, Deborah Schreiber, Richard Appel, Sherry Stanley, and Mark Hamelberg. I found session 4 too, so I'll call you up next. Sorry about that. A lot of papers here. Okay, if you guys could step over that way. Go on. There you go. You don't want to hide behind me. All right. I don't see that we have any in-house questions at this time, so we'll go straight to the ones that were received online. And the first question that we have: all the codes in HPMS for grievances and appeals materials, category 3000, are for model letters. CMS does not provide model letters for all scenarios, for example, response to grievances. How should these be submitted in HPMS? Slide 10, disclaimers when benefits are mentioned. Must the benefit disclaimers be in grievance appeal letters that explain when a certain benefit may or may not be covered and the cost for those benefits, such as copays?
So when we consolidated the marketing codes recently, in some cases, materials that have models and materials that don't have models will be submitted under the same material codes. So that is a possibility. You should still submit them under the appropriate code. And then as for the appeals letters and disclaimers, if the model for that appeals letter or other instructions indicate that the disclaimers are required, then they should be on the appeals letters, but otherwise we don't require them.
Okay, our next question. If the only change to a material is to add or update the disclaimer language in accordance with the new Chapter 3 guidance, does the material need to be resubmitted?
So if there were a number of disclaimers that had changes. So 50.2 has 2 disclaimers that had changes. One of them, which starts off something like, this is not a complete description of plan benefits. The changes to that disclaimer were just language. There were not policy changes there. So you don't have to resubmit materials if that's the only disclaimer that you're changing that requires updating. The other disclaimers, the ones related to benefit changes, those were important changes, and we need documents resubmitted if you need to update those disclaimers. So the ones that talks about co-payments, co-insurance may change January 1st of every year. If you had to make changes, so if you had to remove the formulary, the pharmacy network, and the provider network from that disclaimer, then the material needs to be resubmitted, as well as the one related to limited access to preferred cost-sharing pharmacies. In those cases, the material does need to be resubmitted.
Okay, our next question. What guidance has been given to providers regarding the new MA online provider directory requirements for outreach? And will CMS permit plans to aggregate data through vendors that can confirm provider data without having multiple plan outreach efforts?
So CMS has not discussed this change with providers. We expect plans to communicate with their providers about this change, and plans are allowed to use vendors for this information if you feel that's the most appropriate way to handle it.
Okay, the next question. Does CMS consider gyms and fitness centers to fall under the new provider directory guidance related to monthly network mailings and real-time updates when the fitness benefit is filed as a mandatory supplemental benefit?
No, this requirement would not apply to entities such as gyms.
Okay. One more question here. Does a generic business reply card created by a licensed Medicare sales agent require a CMS approval ID?
No, business reply cards that don't contain plan benefit information don't need to be submitted into HPMS, so they don't require a material ID.
Okay, that is all the time we have for this group. Thank you so much for your participation. Carrie? Okay, we're going to jump back to the session that I skipped, and that session would be parts C and D appeals, insights from Maximus Federal Services, with Rita Worm and Kathleen McInnes. If they stand behind me, you can't see them. All right, I don't want to be the only one up here. All right, the first question that we have received from our viewing audience: when a waiver of liability is not received and a case is dismissed, if it is overturned by the IRE, do we still need to requite the waiver?
If I understood the question correctly, it was if the case is dismissed because it's not timely and we overturn the not timely finding, that you still need to get a waiver? And the answer is yes. You still need to get a waiver, or you still need to get an appointment of representative or whatever, which again may lead to you dismissing the case later.
Guessing that was request, that word. Okay, our next question, there is still no in-house questions, so we will move on. What situation qualifies as lack of medical necessity for Part D denial for an appeal?
I'm going to refer that question back to our Part D project director and ask him to respond for it to be posted.
Okay. So you can look for that one to be posted at a later date. All right, when will plans be able to forward electronic appeals files rather than sending paper copies?
We need to do some testing of the Move It process, which will be an interim process until our portal is up and running in the spring. I would anticipate that it won't take very long, but systems people being systems people, they want to make sure everything's absolutely correct before they do it. So it will take as long as the systems people need.
Okay, and we do have one last question here, and that is, In using the website for data validation, it does not include an indicator regarding timeliness. Although we can self-calculate the data, we do not always come up with the same value, especially with expedited cases where the timeline is based on hours versus days. Is there any way to receive specific timelines from the Maximus or on the website so that we can do real-time validation?
I was asked this question also from someone else who wanted to know why we didn't have a flag on the website that pointed out that you were not timely. Since enrollees use the website, we didn't really want to bring that to their attention, that it wasn't timely. I would say that probably if you look in the reconsideration process manuals, you'll see some very specific timeframes that you would need to follow, having to do with mailing and timeframes pertaining to hours, and that should balance out. If you're checking them each week and you're finding ones that you think you thought you submitted on time and you're finding that they're not timely, pick up the phone and call us or email us and ask, and we'll do some investigation and make sure that the website reflects the accurate data.
Okay, thank you so much, Rita and Kathleen. I would then like to ask for the participants for the Getting Ready for 2016 to join me on stage. That would be Lisa Thorpe, Alicia Banks, Rebecca Randall, Patty Helpenstein, and Jennifer Smith. Oh, and we have a question that is in-house, so go ahead with your question, please.
Hi, my name is Megan Johnson from Etna, and my question is related to the performance audit protocol for 2015 and the changes that were shared today. So the calendar year 2015 protocol was released in February. The spring conference in June provided a lot of additional detail and information to plans that wasn't available to those plans that were audited during that February to June timeframe. There's still a couple audits that are to be done this year. How will that be taken into consideration for those plans that were audited earlier in the year that were not reviewed possibly in the same way based upon the information that was provided during the audit time period? For example, from a scoring or findings perspective.
So a couple of things with regard to that. One, any policy that we changed, we had our audit support contractors go back and look through the audit reports. If conditions that were found were upgraded based on policies that changed, they were downgraded. If there was something that was cited, like an ICAR based on inaccurate universe submission, those conditions were actually pulled. They were removed. So nobody was cited for not having an accurate universe submitted. That won't appear in anybody's final report. Additionally, I would just like to say we're in the final stages of analyzing our annual report, which we issue every year, and we did some additional analysis, and it's showing right now anyway that there is really no significant difference from organizations who are audited in the first 6 months of the year to organizations who are audited in the next 6 months of the year. There's really not much of a change in audit score whatsoever. In some cases, in a lot of cases, in fact, the organizations that went first did better.
Okay, we have a question here from our viewing audience, and that question is, regarding good cause reinstatement determinations, what is the turnaround time from the time the plan receives the reinstatement request to the time that a determination must be made by the plan?
So we outlined in the guidance that was released, I believe, last Thursday, processes specific to what the plans need to do, and in that we indicate that it's 5 days.
Okay, thank you. We do have an in-house question, so go ahead, please.
Hi, this is Wendy Krasner, and I have a question for Lisa. On the prescriber enrollment, so you mentioned that you're pretty hopeful that all the PDE questions have been addressed, and you're working on the letter, the sample letter for plans to send. But what about all the issues with provisional supply and how it relates to transition and the huge amount of uncertainty there? What's the status on
Yeah, I
that piece?
think it was included on my slide, and I didn't actually call it out, but also on one of the slides, we indicated that we would be issuing guidance in the near future on provisional supply and on, what a drug is and that type of thing. So we're working on both guidance, both the sample letter, which should be very shortly for the prescriber outreach, and then the final technical guidance that the plans need to implement the requirement.
Okay, thank you.
Okay, well, that brings us to the end of our Q&A session. And any questions that were sent in that were not addressed, we will make sure that they are answered and then posted on the CTEO website, so please look there for them. Thank you to our speakers today for joining us and staying for the last session. And just a couple more things that I wanted to mention for some closing remarks before you leave. Thank you, of course, to all of our web viewers and our in-house viewers. We appreciate your attendance today, and please complete the post-webcast survey that will be mailed to you shortly, so it should be in your inbox shortly. It will only take a couple of minutes, and CMS really does want your feedback. It will help us to improve any events in the future. After the webcast, also an email will be sent to all people who registered when the audio and video files, the transcripts, presentation slides, and other information are all posted from this event. Fourthly, to obtain your CEU credits for today's event, please refer to page 22 in the conference guide. It will give you instructions on how to make sure you get those credits. And lastly, thank you to all of our presenters today for your dedication and all of your hard work along the way, and to the registration and technical team here at CMS, the volunteers, and of course, all of our participants today. Thank you so much and have a wonderful evening.